Good morning. Great to see all of you again, many of you. I hope that you all received a lot of positive feedback on our first meeting. I certainly did. And to anyone out there, y'all are the experts, no doubt, many of you out there, but from our committee or from anyone who is watching us online particularly, anything we can do to help to make sure that you fully understand the scope of this committee and the issues that we're dealing with and how important they are, please do not hesitate to reach out to me or my office or any of the committee members, because this is a very heartfelt issue. Let's pause just a moment. I'll try to catch my own breath as I fought the beast of traffic to town today. Let's just pause just a moment and start with a prayer. Dear Heavenly Father, we come to you this morning with grateful hearts for another beautiful day in our Georgia. And we ask that you open our ears and our hearts to the somewhat difficult subject matter we're about to take up, and to realize the opportunity and the responsibility we have to face it, emboldened by your courage. Thank you for everyone that traveled here today. Help us to all return safely to the work and the important work that we have ahead. In your name we pray. Amen. Okay.
Your microphone.
It's not on?
I think the volume needs it.
Okay.
I turned it down earlier.
Okay. Are we better? Oh, yeah. I'm sorry. Everybody missed some of that earlier, but here's what we'll do. Okay. So we'll start today. It's our second meeting. And our objective, of course, is to explain the preventative measures, diagnosis, and treatment of social and emotional health. During our last meeting, we learned how the early experiences affect a child's brain architecture and set them on their path for life. We heard from pediatricians, child care providers, and a judge about their experiences with children and families and why they believe social, emotional health for infants and toddlers is so critical. This meeting will focus on the spectrum of services available to infants and toddlers and how certain areas of the state are implementing statewide, system-wide approaches to serving families and the barriers that exist both practitioners and families face in providing and accessing these services, respectively. So we're going to start out this morning and go full steam ahead because there's so much to tackle in this arena. I thank you for being here. Our first speaker will be Dr. Tracy Topple, who is an instructor at UGA and founder of Infant and Early Childhood Mental Health Resource of Georgia. Dr. Topple will provide the context for how child care providers, pediatricians, public health workers, and infant mental health therapists all play such a very important role in preventing, identifying, and treating social emotional health issues for infants and toddlers. Originally from Georgia, Dr. Topple formerly lived in New Mexico, where there is a robust state-supported infant and early childhood mental health system. She's the founder of Infant and Early Childhood Mental Health Resource of Georgia, a licensed independent social worker, and endorsed as an infant mental health therapist in New Mexico. Her clinical experience includes in-home therapeutic services and center-based group work for children ages birth to 3, using evidence-based interventions such as child-parent psychotherapy, circle of security, and dialectical behavioral therapy. Dr. Topple, we look forward to hearing from you, and whichever is most comfortable, whether you prefer to be at the podium or seated at the table. Thank you. Thank you.
Dr. Tracy Topple, and I'm from Georgia. Grew up, born and raised in the K through 12 public school system. I graduated from Georgia Tech.
Can we get the mic?
Oh, I'm sorry. Okay, I'm sorry.
Can you hear me now?
I can't.
Perfect.
Yes, thank you. Keep us on task here. Thank you.
Thank you. So I'm from Georgia, born and raised in McDonough, Georgia, K through 12 public school system. Graduated undergrad at Georgia Tech, finished my graduate work at UGA, and currently a part-time instructor as well, along with the clinical work and consultation work that I'm a part of in Athens. Some might say I'm a conflicted soul, come around Thanksgiving when Georgia Tech and Georgia play. But I'd like to start us off this morning with a bit of an experience. And so, Ms. Arroyo, I have a audio clip to play, and it may be a little loud, and I just wanted to be aware of the volume. Okay. Okay. So what was that like for you to hear that baby crying? What did you notice inside?
Yeah, speak up, speak loud. We want memories, without a doubt. Yeah.
Memories, without a doubt.
Mm-hmm.
Maybe back to the middle of the night memories.
Mm-hmm.
Right.
Mm-hmm.
Got it?
I felt like it was probably going to get louder and
It
more
actually
intense.
was supposed to
My
have
memory.
gotten louder. That was
My
a
memory
shortened
said
clip.
that.
The clip I had before got really loud. And we might notice what that feels like inside of our bodies. It takes us to, what do we want to do? Some of us want to immediately rescue the baby. Where's the baby? What can I do to help the baby? Some of us may want to get as far away as possible from the baby crying. So there's a response that happens inside of us, and we try to get into that state of mind of where our parents are and how they manage the anxiety, how they manage the stress of their own baby as they try to then regulate them. So today what I'd like to do, I want to highlight for you some major points from the last session because I feel like we had so much information that was out there. I did watch the video of the first session, so I was really happy to see all the information that was shared. And then I want to also introduce an area of new science called epigenetics. And then I want to move us into what is infant and early childhood mental health as an applied practice. What does it look like in a practice setting, and what that continuum of services could be in our state for infants, toddlers, and families. I want to introduce you to some of the assessments, tools, as well as manuals that we use for our field. And then some of the evidence-based interventions and treatment models that are currently being used in some parts of the state and certainly being used nationwide in order to reach children that are most at risk. So to remind us again of our definition of infant, and you'll hear many terms. You'll hear infant and early childhood mental health. You'll hear infant mental health. You'll hear infant parent mental health. All of that is synonymous with infants' social emotional development. And what we mean by that is for a child birth to 3 to be able to experience, regulate, manage big emotions, form close and secure interpersonal relationships, and explore and master the environment. So you have this two dynamic of being able to manage really big emotions and safety with a caregiver, as well as being able to separate and explore my environment. Okay? And that comes from our handbook of infant mental health, that definition. So we learned that brain development, we're born with 100 billion of neurons waiting to connect through synapses, and that neurons that fire together wire together. And we know that there's no such thing as a baby. There's a baby and someone. And in our work in infant mental health, we focus on the and. Our work is with the relationship. Our work is not with the caregiver and not with the baby, but the and. So that's where we really target all of our work, because there's a transactional nature to development. And the development is integrated. So what's happening for a child social emotionally impacts the rest of their development. And it's all related. We know that early experiences do matter because of these sensitive critical periods in early childhood brain development, as well as this new fascinating field to me called epigenetics. And what epigenetics really is telling us is that there's no longer this debate between nature versus nurture, because we know it's both. We know that the environment actually alters genetic expression. So what that means is it doesn't alter our genetic makeup, but it alters how our genes are expressed. As if our genetic structure were a library, and we were to walk into the library, and our environment chooses which books get taken off the shelf. And so it's that important. Our environment is that important to develop. So Dr. Johnson talked about that genetic potential that all newborns are born with. And so we really get an opportunity to think about how can we activate the most potential for our children, the most positive way. We also know that the brain's ability to change in response to experience is super high early on, and it decreases as we get older. The malleability of our brain and the amount of effort it takes to then help organize that brain as it grows is lower in the earlier years, and it takes much more effort. I started my practice actually with outpatient intensive with adolescents in a wraparound service model. And the problems that we were encountering in adolescence were a lot more difficult to put support systems around and build resilience. And they were not problems that started overnight. These were not dynamics that suddenly popped up when a child became a teenager. There were early signs early on in the family system. So we know early intervention works. I wanted to point out, and this relates to our interventions and our clinical strategies, is that the brain develops hierarchically. And so that the lower brain is where newborns are born, with the lower brain activated online, and the midbrain, which is our limbic system, where we carry all of our feelings and our emotion center, is developed after birth, as well as the cortex, which is where we think about our cognitive functioning, our executive functioning, and then it develops from the base down. And we just think of that as low, mid, and high brain. And why that's important, in the midbrain is where we house our amygdala. And our amygdala is online at birth, and it's taking in all this information from the external world, which is often our caretaker, their face. And it's fully developed about 18 months of age. And this is where the fear receptor of the brain is housed. And this is so important to understand clinically, because it's dependent on the caregiver to be able to manage and help a young child regulate big emotions. Infants, if you've ever been with an infant, even for 30 minutes. They're modulating between different states the whole from being quiet and alert to being active and alert to being really frustrated and upset. And so it's up to the caregiver to be able to help that infant regulate. And this co-regulations of emotions helps a child then to learn to self-regulate as they develop and grow. I wanted to show you it's called the still face paradigm, and this was developed by Dr. Ed Tronick, and it was a research procedure that was developed back in the 70s and really helped us understand this interactive. When I talk about the interaction, the dynamic, the part that the infant plays as well as the caregiver. So let me get to that.
That ball and fell down the hill.
That was a bit silly.
Not Peppa Pig, a favorite of many kids. Certainly was of mine. All right.
Babies this young are extremely responsive to the emotions and the reactivity and the social interaction that they get from the world around them. This is something that we started studying 30, 40 years ago, when people didn't think that infants could engage in social interaction. In the still face experiment, what the mother did was she sits down and she's playing with her baby who's about a year of age.
I'm like a girl. Oh.
And she gives a greeting to the baby gives a greeting back to her.
Yeah.
This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this, and then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to the mother looking where she points. The baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, "Come on, why aren't we doing this?" Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions, they turn away, they feel the stress of it, they actually may lose control of their posture because of the stress that they're experiencing.
Okay. I'm here. And what are you doing? Oh, yes. Oh, what a big girl.
It's a little like the good, the bad, and the ugly. The good is that normal stuff that goes on, that we all do with our kids. The bad is when something bad happens, but the infant can overcome it. After all, when you stop the still face, the mother and the baby start to play again. The ugly is when you don't give the child any chance to get back to the good. There's no reparation, and they're stuck in that really ugly situation.
What age was that infant again?
Around 9 months.
Great.
Around 9, but they've actually, that experiment has been conducted with infants much younger, around 3 or 4 months, and you do see the same kinds of reactions when the parent withdraws. So what did you notice about that interaction? Any thoughts? Did it surprise you? Anything surprising? Yes, Representative Dickey?
Surprised the heck out of me.
It surprised the heck out of you?
Yeah.
In what ways?
How quickly it was, just how one-on-one, just how.
Yeah. These are relational patterns, right, that get set up right from the very beginning with a caregiver. This is something that's really specific and unique to this couple, right, and how they go back and forth. She tried many ways to get her mom's attention to bring it back. What did it look like when she tried?
Awful.
Okay, before it got awful, what did it look like before that? She smiled. You know, babies are super cute, right? She smiled. She tried to bring her in. She pointed. She tried to do the things to bring her mother in. When that didn't work, what happened? It looked awful. She got quickly upset. It reminds me of a few weeks ago, I was observing in a classroom in a Head Start, actually. It was a Georgia pre-K classroom. And a little boy was dancing around the teacher with his fist up. Says, "I'm gonna beat you up, teacher. I'm gonna beat you up. Beat you up, teacher." And the teacher did not respond and ignored the behavior. A few minutes later, the behavior escalated, right? Everyone was supposed to be sitting down. He was not. He wasn't met with a need of a connection point at that time with that behavior, which was incredibly confusing to the teacher. He then left the group and went over and tried to pull an object off that he knew he wasn't supposed to have. So then what ensued was this battle, pulling an object out of a little 4-year-old's hand. And of course the adult wins because we're stronger, right? Pull it up, we win. She turns around, and what did he do? He hit her as hard as he could in the back with his fist, which then escalated everything else. So when young children are not met with what pulling in for a social emotional connection, behaviors tend to escalate because getting something is better than nothing. And so we want to try to help parents understand what are the early signs, what are the connection signs that children are showing us with their behavior. What does it mean? What are they trying to tell us? We know that some of this for children, when it's day in and day out, this chronic traumatic stress that they live in, we learned a lot about the risk factors, but they're not predictive because of protective factors. So we have an opportunity in Georgia to set our kids up with what we really know are protective factors. And so what that looks like in our field in infant early childhood mental health is there's a continuum of services. So this is a field of practice that focuses on families with young children prenatal, because we already know some risk factors before the child's even born to age 3 to 5. And that along the continuum of services is promotion, prevention, intervention, and treatment. Now, I do want to remind us, we're going to be talking a lot today about intervention and treatment and services for children. And that's when the relationship is already to the point that it risks damaging the developing child's brain architecture. But all of these, from promotion to treatment in infant and early childhood mental health, is considered prevention because we're working with really young children. We're preventing the later onset of behavioral and mental health as well as physical problems as children age in their adolescence years and into adulthood. So as an applied practice, infant and early childhood mental health is interdisciplinary. This is a really important point. No one discipline owns infant and early childhood mental health. The healthcare profession, we heard from pediatricians, child welfare certainly, mental health clinicians, early intervention specialists, developmental specialists, some of our home visiting programs that help with emotional support for families, our early care and education. So many different disciplines coming together and understanding some of the common predictions and risk factors and protective factors for really young children. It's also competency-based because we recognize and understand working with families and young children is different than working with older children. There is a certain skill set in being able to help a parent in that interactive repair process, the dynamic of that back and forth of how the relationship patterns get set up and how it impacts kids. And there's also a focus on relationships. And this is important because we really are hoping to model what it means to be in healthy relationships for the caregiver and the child. But that also means that the caregiver and provider have that trusting relationship that we're wanting our families also to have with their children. It means that the caregiver has an environment and a community where there's relationship and trust. It means that between providers we share information and there's a trust and we're on the same page about what is best for our most vulnerable children. So it really is a field that puts a lot of emphasis on relationships, on relationship building. what that might look like as support services. So I have here this graphic, and it's really small to read. I'm going to go through it. In the center is the specialist. And that specialist, an infant and early childhood mental health specialist, could work in an agency, an organization, or a center, or they could also provide services in the home, which is a really common place to meet families. And the surrounding that specialist are all the many different areas in which they would work. So Dr. Johnson talked about the importance of having case management. So part of that work with families with young children is really the concrete support and helping them get connected to services. A big part of what an infant and early childhood mental health specialist does is early relationship assessments. And we have tools for that. We know how to measure that, even in really young babies, how to look at that relationship back and forth. My colleague, Ms. Bragg, is going to talk to you later about child-parent psychotherapy. And that is also an evidence-based intervention designed to strengthen secure relationships. The specialist also provides developmental guidance, so they work closely with maybe early intervention programs or pediatricians. And certainly there's the emotional support that a specialist provides in helping caregivers manage difficult emotions or experiences from the past that they're dealing with unresolved grief and loss or trauma in their own lives. So those are the variety of services that you would find. As well as in early care and education. We'll have the opportunity to talk about how we're infusing that in pre-K classrooms with Head Start and Early Head Start in a bit. So some of the screenings that we use for these services are standardized tools that you can find available that are used in many, many places working with young children. Some of it you were introduced to last session when we talked about the ACE scores, the Adverse Childhood Experience scores. And that's a screener that can be used even prenatally, because we know that if a caregiver has had a lot of adversity in early childhood, there's greater risk for her baby. So to be able to set support systems up right from the very beginning. Depression scales for caregivers, because there's a robust connection between maternal depression and outcomes for children in social emotional development. That's something early on we can screen for. Parental stress index, stress is also an indicator. There's also tools that look directly at infant and toddler social emotional development, trauma symptoms, child behavior checklists, and there's interview guides that help us understand how a parent may be thinking about the relationship with their child. Because there's some predictive validity to that early on about how I'm considering my child, how I am thinking about our relationship early on can help inform interventions. So to think about specifically, this is a screener that was developed for child-parent psychotherapy, but these are the kinds of things we look for. So with really young children, birth to 5, if they've had a problem that's lasts for longer than 1 month, that happens often or is stronger than expected for a child's age. So if the parent has concern or another provider has concern, and these can be things around bodily functions, sleeping, feeding, potty training, or going to the bathroom. Those are definitely areas of concern early on for children. Upset by noise, touch, or smells, noticing developmental delays, and this could be either from a single event trauma or a chronic environment that's unpredictable. Health problems, emotional difficulties such as anger or tantrums that last much longer than expected for a child that age, or if the child demonstrates as being sad or cries a lot or overly worried, or there's challenging behaviors of aggression, recklessness. I'm working with a mom now, and her 3-year-old will just take off running as quick as he can from her, which is not a typical behavior. Children usually in new environments want to be close to their caregiver, but whenever they get to a parking lot or somewhere that is a bit dangerous, he will take off as fast as he can and shoot across the parking lot, which in turn for her is a moment of anxiety, and then we have an interaction that's not so pleasant that happens. And so this reckless behavior of not knowing what's safe or is safe, and of course the relationship difficulties. So these are just some of the tangible. I wanted you to see that they're very tangible, specific observable behaviors in really young children that can indicate that they would need more support with their interaction with their caregiver and helping the caregiver to provide that safety net for them. We also use what is called the DC 0 to 5, and I brought a copy of it today. It's our Diagnostic Classification for Mental Health and Developmental Disorders of Infancy and Early Childhood. So this, from experts and professionals in the field, is like our DSM for mental health disorders for older children, adolescents, and adults. And so this is really important because since we are an interdisciplinary field, we need to know what we're talking about and be on the same page. And so this gives us very tangible ways to understand clinical disorders as they manifest with really young children, put it in a relationship context. We also consider physical health, the environmental stressors, and where a child is in their developmental competence. All of that is considered in a robust assessment from observation, parent interviews, seeing the child in different environments. And what's important about this DC 0 to 5 is there's a crosswalk to the DSM-5, which is our manual for mental health disorders for older children and adults, and the ICD-10, so that there is a clear way of billing structure to be able to be on the same page with many different professionals providing services to children and what we're seeing and talking about. So earlier I talked about infant and early childhood mental health being on a continuum from promotion end services all the way to treatment end. And so our promotion services are more of our public health initiatives and awareness campaigns of what's good for all babies and what we know leads to thriving and nurturing caregiving. Our prevention services are some of the home visiting services that we already have here in Georgia, such as Healthy Families, the Early Head Start, Nurse-Family Partnership, Parents as Teachers. These are certainly an incredible part of what we do to support parents. And to be able to support these programs and to reach into more rural districts that don't have access to some of these resources is incredibly important. And then we move into the intervention and the treatment end services. And these services, using our DC 0 to 5, when we look at relationship disorders, allows us to then to look at behaviors in the actual caregiving relationship with the child and rate them from a 1 to a 4. And children scoring 3 and 4 means there's disturbances in the relationship that really are impairing the child's functioning. And so those children would be most appropriate for intervention and treatment in services. And these really are given by master's level mental health clinicians with the competency training to work with young children. And that is something I feel that we are missing here in the state of Georgia, is those kinds of services targeted. Now, all of it from promotion to intervention and treatment then would coordinate with programs like early intervention services for Babies Can't Wait in those screeners. Okay. So what does intervention and treatment look like? I've pulled out 3 and highlighted 3 different intervention and treatment and evidence-based programs. And child-parent psychotherapy certainly is the one that is got the most evidence-based, and it's used around the country and actually internationally. Ms. Bragg from Chris 180 is going to give you more detail on that. It's a long-term treatment. This is where we're working with families from 1 year, 2 years, sometimes longer. I've worked with one family for 5 years using this model. The next is Circle Security, and this is the model that I'm using currently in Athens in the Head Start in the programs, Early Head Start and Head Start programs. And it can be delivered in an individual basis and treat parents in the treatment end, or it can be delivered in a group basis. And it's an 8-week model that uses a manualized DVD, and we help parents observe interactions with children and really understand what the behavior is telling them about their social emotional need. What is it that my child needs from me? And it's been incredibly successful in our program in Athens in helping parents come together, get the support that they need, as well as learn about what their children might be telling them. The last is parent-child interaction therapy. Currently at Emory has a program with PCIT, and it is also more of a short-term, 12 to 20 week, although a parent can continue afterwards. It's certainly not. They're done when the parent feels like they've mastered the skills. And this is a center-based. It's not given in the home. It's a modeling, a coaching technique where a parent has a little microphone in their ear, and the clinicians behind the mirror, and they guide them through interactions and model that behavior. And there's also relationship building incorporated into that. I believe you'll have a presentation about that later on. Okay. I also highlighted a program called Child First that was started in Connecticut. And this is a home visiting program that is a treatment end that integrates child-parent psychotherapy with case management, and it is now being replicated and has a lot of promising evidence around the country. It was began by a pediatrician. To give you an idea of what kinds of things would we do, for example, like in Circle of Security. Yes?
Can you help me understand on the programs, how does a parent, do they opt into that?
Yes.
How does
that
that
is a
work?
really good question.
And how
That's
many parents are participating in the program at Emory and the other program, the one in Athens?
Well, I can only speak to the program in Athens. And we're actually going to have an opportunity afterwards to sit and talk about how we're running that model. But it is a the parents opt in, and we actually have parents saying, I need this. We have a waiting list for parents. Our Spanish-speaking group we didn't have capacity to even be able to serve all the parents.
So what is
that were
capacity?
So each group we can have 8 to 12 families. It's intensive, and because we meet every week, and so you have to have trained facilitators. And so we're running these groups ongoing every 8 weeks in English-speaking and Spanish-speaking groups with anywhere from 5 to 10 families in each group.
And how do the families find out about the program?
Through the Early Education Center. And so all of our families that have opportunities for this group are invited through a grant that we received from the Governor's Office of Student Achievement, and we'll talk about how that money has allowed us, that funding, to open up these parenting programs at no cost for families.
Yeah, that's interesting. So Emory, you don't know how they
I
make
do
the
not,
parents
but
aware of that?
Yeah.
We'll have someone from Emory come in, I believe, in the 4th session.
Okay.
So you can ask her more about
Okay. And that Connecticut program, don't know how
That Connecticut program is actually state funded.
state funded.
It's
Okay.
state funded. And
Thank
you
you.
can, I have the website, I have a video that shows an interaction of what that looks like in the home for these families, but it's state funded.
Thank you.
Okay. And I do believe they've received some foundation funding from, okay. All right, so Circle of Security. Sure. Yes.
Both Wes and I are jumping ahead and interrupting your
That is quite okay. Thank you. I'm happy to have questions.
diagnostic code means billing.
Yes, it does.
And the diagnostic codes that you have talked to us about, does Medicaid pay for those codes?
In some states, yes.
In Georgia?
In Georgia, no.
Okay.
In Georgia, no.
And
However, it has a crosswalk to some codes that are covered in the state of Georgia.
does my state state insurance pay for those codes?
For the DSM, yes, the crosswalk.
So we're
Not for DC, not for this manual, for the DC 0 to 5, no.
in Georgia, there's not a crosswalk in Georgia. The
So
crosswalks are in
y'all are going to explain to us what if we believe that code, that diagnostic intervention should be billable to Medicaid. You're going to explain to us how we could help make that happen.
Certainly, we will try to work with you as much as we can to look at other models and how it's been done in other parts of the
The
country.
families that come to you in Clark County,
Yes.
how do they find out about you? Are these only Head Start families?
Currently, right now, it is only funded for families participating in Head Start and Early Head Start.
And I think this may be part of your program too, and I apologize for jumping
That's
ahead.
okay.
I have been aware of and involved with various home visiting programs over time, and they seem to they're very highly favored. And originally 2 generations ago, that's what visiting nurses did in our
That's
public
right,
health. So
right.
you're going to explain to me today what the status of home visiting programs are, either from public health or from any other entity.
I am not going to explain that per se, but is there
Somebody's-
someone on the docket that was talking about? Yes. Galloway.
Okay, good. Thank you.
Yes. Yes. It's an important part of the structure of the home visiting programs and how we reach families in their home.
And DECAL, I know that DECAL works closely with Head Start, and that y'all have done a lot of progress in the area of joint services, and you're going to explain to me, somebody's going to explain to me DECAL's openness to this new intervention.
Yes, actually. Mhm. You might want to speak to that. Great.
Thank
Okay.
you. We're sorry for our impatience.
No, I'm so glad that you're interested.
One
Yes.
more enthusiastic response, okay?
Okay, yes.
Well,
Chairman Dickens.
I'm just kind of following up on that line. So these families that you're servicing with these services, they were referred by Head Start and Early Head Start.
That's correct.
So due to some sort of screening or some sort of need,
That is
who did the assessment? How did they do the assessment and just trying to?
How did they find their way to the program? And so the parenting programs that we have at Head Start and Early Head Start are open to all parents. So they are advertised at the school. However, teachers, through observations in the classroom, observations because our teachers also do home visits, have recommended some parents to the program.
Okay, so
Now,
some maybe need the services and some maybe not necessarily really are in need
Well,
of
we
the
we believe that all the families benefit from the
Okay,
services.
that's all right. I'm trying to find out. Your program any child would benefit or family
Yes,
would
I
benefit.
myself personally have benefited greatly from this material. I have 2 children, a 10-year-old and an 8-year-old.
Okay, that's what I was
Yes.
trying to understand.
Yes.
Thank you.
So, and when we talk specifically about Circle Security, this is a program that can be used along the continuum of services when we talk about prevention for any family. But when we also talk about intervention and treatment, it's built into the module to be able to be given at a much more individualized treatment end and targeting certain relational patterns that help children feel safer to then be able to explore their world and learn. You're welcome. Yes.
Is there any partnering with faith-based organizations in the community at all to host these kind of events?
There hasn't been, but that is something that we really would be an important piece to this. As people find safety in their community, a big part of the Circle Security curriculum is about being competent hands for your child. And in order to do that, you also, as a caregiver, have to have someone that is supporting you. And we certainly encourage our families, whether that's it's a partner, if it's a family member, if it's their faith that helps support them, to get in touch or connected with whatever gives them strength and resource. And it's certainly a wonderful area to explore.
Thank you.
My last
Yes.
question. I'm trying to remember, there are under 20,000 Head Start slots, 17,000. How many Head Start slots are?
There's 24,000 Head Start and only 4,000 and change early Head Start.
Thank you.
Mm-hmm. So we're talking about a small number that we're reaching here with this. Okay. I was going to go through the Circle Security, but we will move on for time. How am I doing with time? Is it time, right?
You're
Okay.
fine. You're fine with that. You're fine. If there's something you think we need to know, let us know.
Well, I think it's important to understand what we're doing in intervention and treatment with families. It's not it's something very tangible and specific and concrete. And so this graphic shows we spend 8 weeks talking about being bigger, stronger, wiser, and kind with our children. We talk about the importance of children feeling safe to be able then to go out and explore their environment. This gives us very specific and concrete things for the caregiver. When your child is out exploring, it doesn't mean get on your cell phone. It means watch over me. It means delight in me. It means help me when I need that scaffolding. It means enjoy with me. Get on the ground and play, right? But then something happens, and our children need us to be available to them. And so then we spend a lot of time talking about welcoming them in. So when your child has a big emotion, we might not be able to delight in the behavior that they're showing us, but we certainly can delight that they're turning to us to help them solve that. So to be able to delight in that, provide protection for them, comfort, and organize their feelings. And that's what we ask parents to do. And we just take them through the circle. Are they on the top or the bottom? What do they need? We talked a lot the last session about changing the conversation of what's wrong with you to what happened to you. And we're in this moment, it's happening for our young children. And so the question we have our parents ask is, what do they need from me? What is their need? So we try to really get the underlying emotional need. And we do that by being bigger, stronger, wiser, and kind. And we balance that for helping our parents balance that with their young children. So some of the treatment goals that we might find across all of the interventions that I've talked about with child-parent psychotherapy, or with circle security, or with the parent-child interaction therapy, is we're really hoping to increase the caregiver's sensitivity to see from the child's perspective. Can I get into touch of what it's like from my child's eyes? Can I also remember what it was like to be a child? Because if I can get in touch with that experience and remember what it was like to be that little child, I'm much more likely to be empathic with my child. We want to increase nurturing, responsive, and protective caregiving relationships. By doing so, decrease the problem behaviors, decrease depression in the caregiver, and increase the regulation for the child around big emotions. Ultimately decreasing abuse and neglect, and increasing the family stability and connections to the supports they need. So these would be some common goals that might be in a treatment plan for a really young child. We can measure every single one of those. We know how to do that clinically. And the ultimate impact is a society that values healthy relationships in which all have equal opportunity to be physically, cognitively, and emotionally well. And that's what we're hoping by reaching our most vulnerable young children and their needs.
Excellent.
Right. I do have some recommendations of what I feel like
those. Thank you.
our needs. And from my perspective, and people may have other ideas, but that Georgia needs a coordinated system of care for mental health needs that reaches across disciplines. I believe it was Dr. Johnson that talked about the referral system of being able to share information. We also need workforce development and competency level training. That is a big gap in what we have with working with really young children, is understanding and getting up to date on what science is telling us about early childhood. We need a clear Medicaid billing structure and codes to be able then to be reimbursed for that very unique work that is for clinical work for young children and families, and funding streams to be able to do that, which is one of the biggest challenges, right? And as far as I do not know the numbers, but I know that there have been studies and analysis done on the return and investment. But this came from the Center on the Developing Child, that from a policy perspective, it is in society's interest to strengthen the foundations of healthy brain architecture in all young children to maximize the return on future investments in education, health, and workforce development. And we know how to start with that.
Thank you.
Thank you.
So much. So I'm going to ask everybody to take a breath. We're not ending this discussion. We're getting ready to go to the next step in it, and we
Yes.
have.
And so now what I would really like to do is invite my partners from the Early Learning Center and the Clark County School District. So this Head Start and Early Head Start, we're going to sit here at the table and have a conversation about how we've tried to start creating a bit of a system in Athens, coordinated system between providers in meeting young children. It's by no means fully developed. It's in its baby stages, and we're happy to fill you in or talk about the work that we're doing there and the impact that we see.
Okay. Okay, just making sure we have enough chairs. I have.
We do.
Okay, I had
And
5 names, but I don't know if we
yes,
have.
and
that
so
many,
one of my colleagues, Robin O'Donnell, she was unable to join us. Her child had a fever last night, so she was unfortunately unable. But I can speak from her perspective of some of the work. She's from Children's First.
Well, that is great, and she's right where she needs to be. That's what
Exactly, right.
matters. Thank y'all for being here. I'm going to let you take just a moment to introduce yourselves too before we get started here, so that everyone up here is well aware of who you are. And the microphone, you may have to move it and get kind of close to it so that it will be loud. We got to remember that we have people listening in and watching very closely, so I want to make sure they can pay attention too.
We'll try to be able to share it back and forth. I'm Karen Higginbotham, Director for the Office of Early Learning in Clark County School District.
My name is Angie Moon de Avila, and I'm the coordinator for the Early Head Start and Head Start program for the Clark County School District.
Good morning. My name is Marsha Hawkins, and I am the program specialist for Early Head Start in Clark County.
Thank you so much. Dr. Topple, we'll turn it right back over to you.
Okay, great. So we are excited to share the work that the Clark County School District has undergone, and I think it's a really big work. To my knowledge, the only school district that I know in the state of Georgia that is infiltrated relationship-based practices from the administrative to the teachers to the staff, in really educating around early childhood development, early childhood brain development, social emotional development. And so I would like for them just to have a chance to talk about the process and what they're seeing from the work that they're doing.
So our initial goal when we were working through or beginning this work was really about looking at ways that we could strengthen the language and literacy for our students, to strengthen their school readiness, to make sure that they had the foundational skills that they needed to be successful as they launched into school from us at the Early Learning Center. Some of the work that we were noticing is not only just and we work together with our K-3 coach in addition to our coaches from the Early Learning Center to work together. And as we continue to work through that process, we were really looking at throwing more literacy wasn't as effective of a solution. It was in the right direction, but it wasn't enough. And that, if I have a child who's struggling with language and literacy or struggling with math, simply adding more math or more literacy wasn't getting us to the results that we really desired. And so we were starting to look at the reasons, the actions, the things behind that, and recognizing that, while it's very popular to say, well, they're in poverty, therefore they can't. It's really not about the poverty. Really, for us, we were discovering is behavioral, but it was behavioral around those adverse childhood experiences. And so children who had adverse childhood experiences, who perhaps grew up in poverty or not, but had buffers, had someone, standing between them and the events of life that altered their impacts or their choices, that perhaps there wasn't money in the home, but, you hear folks talking about, we didn't realize we were poor, we were rich in other ways. And that's really the situation for a lot of, families. But then we had children whose perhaps had means, but parents were going through a divorce, and it was very contentious, and the children were in the middle, and then the trauma is impacting them, and impacting them in some very important and, brain archaeological ways. And so we were looking at it from that perspective. We did apply for the GOSA grant, and went through, as part of our work with that, we worked on it from a teaching perspective of what kind of professional learning did we need to provide for our teachers. So we were getting children who were coming to us without the buffers they need. Our theory was that if we began a pilot with children and working through how we could help them develop the language around being their own buffer, the problem-solving skills, some of the things, ways to express their needs, ways for them to be able to pay attention, to persist. And so working with our teachers, we worked through some of the studies that Georgia State is doing around trauma-informed care and provided our teachers with that training. We also worked with the APEX grant, and they came and gave our teachers some of the professional learning around secondary trauma, because teachers are empathic and they tend to carry the weight of their children's scenarios with them. We worked on equity work. We worked on building language through instructional conversations and helping them.
Got a question.
Okay.
Representative.
I'm trying to figure out who we and us is.
Oh, I'm sorry.
Because you are the school system, but you have partnered with Head Start because your school system has an early child learning division.
Yeah, so.
And early starts at 3 or early starts at 2?
For us at the Early Learning Center, we have early Head Start, preschool special education, and pre-K within our Early Learning Center.
Clark
so we
County
have
School
at
System.
Clark County School System. So I'm the director for the Early Learning, Office of Early Learning, which includes our Early Learning Center, but also includes all of the pre-K programs throughout our county. And so we work together, and the I apologize, is Clark County School.
My friends here may be going through the same mental thing, calculations.
I'm glad you asked.
Because Decatur has an early, City of Decatur school system, but DeKalb County has something different. So I'm trying to put all that together as you're talking about we.
Yeah, and there are several counties, pre-K is, across the state. Some of it is in private, exclusively counties have it in private centers. Some have it within a blend of private and
But
some
it's
within
getting
the
below
Clark County.
age 4 for most of the 180
And-
school districts that we're talking about.
Yes, and
Need is, where the
yes,
need is.
and that's where our pre-K program is pretty, across the state. The early Head Start and Head Start, as she pointed out, there's really only about 25,000 seats.
Representative Oliver, their early Head Start classrooms, so center-based classrooms, start at 6 weeks. So 6 weeks to age 4 is the population that they're serving in their center, and prenatally in the home visitors to the early Head
And that's
Start.
Clark County School System.
It is, and the Clark County Board of Education is our Early Head Start and Head Start governing board. And we have
Thank
a
you.
parent policy council, and I apologize for not clarifying that sooner.
Thank you.
I wanted to see if I could go back to some of the questions that you guys had asked a few minutes ago about how parents join. And within the Clark County School District Office of Early Learning, we have about 1,100 children total that we're serving. Our county has about 7,000 children under the age of 5, and 35% of those children live below the poverty level. So for the Early Head Start and Head Start program, we, all programs in the United States are to identify children who are most at risk for not being ready for kindergarten. And so if you can imagine the scenarios that we have a teen parent or a homeless family or a family who's suffering from addiction or domestic violence, and a combination of those. And when you did your research with us, what was the percent?
So at the Head Start Center of 112 students, we had 57% of those students had 3 or more adversities. And those were big adversities that we measured, like parent incarceration, parental mental illness, homelessness. And I think the average is around 10% that Dr. Johnson talked about. At this age and that population, national trends are around 10% of children at this age would have experienced 3 or more. And now that's important to note, because what we know about adversity is cumulative. It's not linear. It's not one adversity and then you have more difficulties. It's if you hit a threshold that things tend to unravel. And so that at our center, we're serving a population that has experienced a lot of adversity really early on.
And that's part of, through the GHOST grant, is part of how we got connected to begin with. Part of our work, we realized that we needed to do the language and literacy, but we also needed to do the social emotional step. And so while we were working, within the Georgia early learning developmental standards, there are social emotional components. Within Clark County School District, part of our strategic plans is the language and literacy, but also that social emotional growth. Sort of in the perfect storm, Head Start had also required to pick a parenting curriculum. And so at the same point that we were researching areas of within our GOSA grant and support systems, Head Start was also had their compendium of resources to pick from for parenting curriculum. We used parents as teachers, but we also began exploring the circle of security. And for us, we were one of the first that really looked into utilizing it not just for the home caregiver, but also for the school-based or the center-based caregiver, so that we began to have that common language. And so when you're asking about, how do they get involved, part of how they got involved with us was through our grant, and therefore it was a pilot and a smaller group to begin with. But the idea of what we're doing is really in a preventative type measure. It's really getting parents connected to the information, looking for it. The depth that Circle of Security has available to it in a more interactive or clinical way, we don't reach to, because that wasn't our initial goal for it. It's really about having parents have the exposure and the experience with the program to be able to learn and do some recognition and preventative pieces. To go to that kind of deeper point would require a specialist.
So the other piece that I was wanting to respond to is the joint services. You asked about DECAL. And Department of Early Care and Learning is also an Early Head Start grantee through the Early Head Start Child Care Partnerships. And so for the second time, we hosted Circle of Security facilitator training. One was 2 years ago, and one was this past July. And DECAL has had their Early Head Start Child Care Partnership staff to attend these sessions, and they are beginning to implement this parenting curriculum. And so from my experience, extremely open and understanding of the interventions that we need for our early Head Start and Head Start children. And as Karen was mentioning, it wasn't enough for us to look at the fact that we have literacy challenges in our communities in Georgia, but to realize that throwing additional literacy interventions on top of existing literacy interventions wasn't giving us the growth that we were looking for. And so as we went through our root cause analysis and identified the ACEs, and participated in those trainings through Georgia State University and through Circle of Security, we realized that this was the missing link for us in helping families establish healthy relationships and bonding, attachment and bonding. And Marcia, did you?
Marcia is going to speak a little bit about the response of our families. And so what's important to understand is we have been using this framework with the teachers, so all 65 teachers or so now are trained in Circle of Security, which is looking at how to identify social emotional needs underneath the behavior, as well as now we've graduated about 30 families. The administrators have been trained in it, as well as some staff. And so we're really looking at infusing this way of being in relationship throughout the center. And so Marcia has had the privilege of running groups with families.
So you asked about parent trainings. I saw that at the last meeting. I was researching these meetings. So parent trainings are important, but they start with a relationship. So you asked, how do I join? You join by knowing me. So if I have a good relationship with you and I express how well this Circle of Security is going, you'll want to join. So every parent needs to join the Circle of Security, because we're going to teach you some things. We're going to teach you some things that no book gave us when we had these babies. So now you need to connect with somebody that has the experience. So we're offering this training to all parents. First thing we want to know is, why do you want to join? And it's because we know you want to join because you want to learn more about your child. We're asking you to really look at your child, observe your child, but first of all, build a relationship with them. From that little crying video Tracy just showed you, how many of y'all wanted to move away from that baby crying? I know I did. But then I started looking at faces and saying, let me go get that little baby. Where is she? I started looking out in the back of the room. Where is that baby? Because we all have that little shark inside of us saying, oh, I need to do something. Something is happening. So if we teach you that, you'll know what to do when you hear that, right? You'll know how to respond. So this parent training, the circle of security, is important to all parents, not just the parents that are in poverty, but all parents. Because if you have a baby, they don't come with instructions, so please teach me. You know, and what we're hearing from our parents is, I wish I would have got this when I was pregnant, or I wish I would have got this, you know, when I was planning to get pregnant. But now I have a baby. What do you want me to do with it? We want you to observe it. We want you to observe this baby going around our circle. So where is the baby, and where are you, Mom? Where are your hands? When that baby is on the top of the circle, are you watching me while I play? Now I bump myself. Are you still watching me when I come to you? Are your hands open to receive me? Because I'm crying now. Can you receive me, or are you thinking about your childhood? What happened when you were crying? Did somebody have their hands open for you? So a lot of times we're reflecting. This is all about reflecting on, you know, your experience. So, you know, Clark County, we are working with the in Head Start, early Head Start, working with some high-risk parents. We get the opportunity, I get the opportunity as the program specialist to actually look at their situation when they come into the program. So we do a selection criteria. We're trying to find out, are you coming in with mental health problems? Are you coming in with low income? What do we need to do to help you, Mom and Dad? Because we're gonna get to the baby. Our teachers are waiting to receive that baby. But what about you, Mom? And when the parents are in our trainings, Tracy has really been a great trainer. She's trained us how to use our hands as supporting the parents. So when they come in, they're stressed out because now they're in a group, what they call a support group. What I call is a parent training, but it becomes a support group. Now we're all in here together as parents saying, you know, this is what I went through as a child. I don't want my child to go through that experience. Tracy is teaching us how to observe that baby a little bit more, observe your teenager, because they're going to grow up. So as they go around this circle, what we're teaching them, as even a teenager, when they go out of your home to go out to the club or be with their friends, what are you doing when they come back? Are your arms still wide open? Are your hands open to receive me when I come home? That's what we miss. I think what we miss is when the babies start growing up, that teenager or that terrible two, because we ask our parents, what happened in Walmart? Oh, he's falling out. Yeah, I don't want to be a parent at that time. I want to be a parent when they're always doing good. But that's just not reality, is it? We got to be there when they fall out, and we got to be there to help them get up. And it takes some time to do that. When they're having that tantrum, how much time are you going to give it? You know? Come on, let's get up. I see you down there. You want me? What do you want to tell me? What is your body telling me? This is all observing. You have to observe. And as we grow up as people, we still have to observe each other. How do you feel today? Oh, great. No, how do you really feel today? You know, because everybody has that mental health that they need to. We need a lot of that. I need you to call my name to perk me up in the morning. You know, we got a great director that stands at the door and welcome us into the building, That's great relationships. When you can call somebody by their name, that's a great relationship. And that's what we tell all of our parents.
And Marcia, it's a privilege when you sit with some of the families, when they have this moment where they are able to get to a space to reflect on their own childhood. Yes. And they say, I didn't get this when I was growing up, because I feel safe enough to share that. I'm thinking of a particular mom. The last couple of weeks, we do an exercise where we think about all the emotions that were supported for us, or not supported, or partially supported in our childhood. And she broke down in tears. And she
shared with us that she was in foster care in her teenage years, and she had no one that she could share these emotions with. And now she has an 18-year-old and a 3-year-old, and she wants to do it differently. She had never shared with her daughter, her 18-year-old, that she was in foster care growing up, and she says she hasn't shared it with many people because it feels so shameful. But when she was able to make the connections that she needed support with her child and to see the insight that starts to happen, you know you've made a difference for that family. When a parent says, I now know how to discipline without hitting, you know you just changed the trajectory of a 2-year-old. It's important work.
So in terms of next steps, what we're faced here in Clark County and in Georgia is that through the Early Head Start and Head Start program and through our short-term GOSA grant funding, we have the capacity to implement this parenting intervention. When we receive a parent like the one that Tracy was just speaking about, who actually needs a treatment model, we don't have a referral source, and there isn't a billing mechanism for that, for this type of intervention like Circle of Security. And so where do we go from here? Where will the parents that we're talking about today go and receive those intervention services? The child with the delays in the language and developmental delays, yes, we refer to Babies Can't Wait. But many of the children that we work with, they're not delayed. They're traumatized by their experiences in the home, and they're not eligible for these services. They're not getting those services, and that continues to manifest as they get older and bigger and stronger. When we have 2-year-olds and 3-year-olds throwing chairs and flipping tables, but they have good language. You know, they're not a referral for Babies Can't Wait, or they're not, becoming eligible for those services. And we have found that a lot. Very, very sharp, intelligent, cognitively on-target children, but don't have a mechanism for organizing their emotions because the emotions aren't organized for her or him as well. So where do we go from here? We have a gap in services right now for our youngest children under the age of 3. I also wanted to mention that we also have home visitation services where we provide weekly 90-minute home visits for 100 families, 20 of whom are expectant mothers. And we've also run Circle of Security groups for those home visitation groups.
I have one more thing I'd like to add. Another piece of the model in Athens, and Robin O'Donnell, who was representing Children's First in the Department of Public Health in that district, was unable to be with us, but she has organized monthly trainings for all the home visitors in our county. And so once a month we've been meeting now, we've had 3, and we'll continue for 10 series of bringing this kind of training and information to home visitors to be able to support the relational interactions with their families on their caseload. And so we have home visitors that are coming from Babies Can't Wait, mainly from Babies Can't Wait at that point, but from Children's First as well as from Bright Paths and parents as teachers that are taking part in those monthly trainings. So we've started organizing around workforce development, but we have a long ways to go.
Well, you've done a lot too. So, Representative Oliver.
It sounds like the GOSA grant gave you an initial opportunity to do this coordination. How much was that grant? I'm just curious. Do you remember?
It was a little over $600,000.
And then the next step, from my perspective, just understanding it, is what does Babies Can't Wait do for the population you've identified? And somebody's going to explain that to me sometime today.
Babies Can't Wait.
Because
Babies Can't Wait is our Part C provider. So at the school district, we have preschool special education that begins at age 3. We have a understanding with Babies Can't Wait, and they are serving children under the age of 3 with identified special needs, not within the mental health capacity, but within.
That's a unique arrangement y'all have created in Clark County.
Babies Can't Wait exists across Georgia. The work that we do with Babies Can't Wait, we have a close association as they transition from the Babies Can't Wait services to our preschool special education service, but that's across the state of Georgia. That's not unique to us.
And when you mention your home visitors, those are people paid by public health. I'm just trying to figure out all the
Those were actually part of our early Head Start program.
Okay.
So Babies Can't Wait, I'm not a Babies Can't Wait representative, but from what I understand, you have to have a diagnosable developmental delay in order to receive services from Babies Can't Wait, or at risk. And currently, social, emotional, and mental health is not part of that qualification. Is that correct? Yeah, okay. That would be great. Thank you.
Somebody's going to give me a chart.
We need a chart, right? We need a chart. We certainly need a chart.
Yeah, we'll work on that. Thank you. Thank you for your questions. Chairman Dickey.
Thank you, Representative Oliver. That's kind of where I'm going to. I just really see the passion, and thank you, ladies, for being here. I mean, I just know y'all got so much work to do there in Clark County, and I just see that you want it done. And I'm trying to figure out also, how long has this program been going on, different that y'all doing maybe than other areas, and how much of a difference are you seeing or you think you're seeing? And but along those lines, could you expand a little bit?
And I would love to say that it's unique to Clark County. Unfortunately, this is a battle that I think is going on in all of the counties throughout Georgia. We're more unique in that we have an early learning center as part of our school district.
Okay.
But the truth is that it's, based on the Head Start leadership meetings in the last couple of weeks, it's something that's happening across Georgia. But for us, we've had the grant now for not quite 2 years. And so we are seeing both academic and social emotional gains. We have experiences where we had teachers that are beginning to feel comfortable with being able to say, you know what, it's not spoiling them to pick them up and hold on to them right now. It's what they emotionally need from me right now. And so, being picked up or carried when I'm fussing isn't teaching me to cry. It's really teaching me that you're going to be there for me each time and every time that I need you, in the same way that our parents are beginning to. And, you hear they'll cry themselves to sleep and they'll learn how to do that. Well, they'll also learn how to go to sleep without having to cry themselves to sleep each night. And we know that now. And there's a lot of things that we've learned over time. But for us, within the last 2 years of our work, we're helping kids learn to have the language of problem solving, and for teachers to recognize that my behavior is not personal to the situation. And you may not recognize what that trigger for that behavior is, but there was something that triggered my behavior. And the trigger might not be recognizable to you, but it was something that triggered my behavior to me, something that in my past has created a situation for me that's going to create that behavior. And if I can help you develop the social emotional skills around expressing it in a positive way, instead of winging the block to show you that I'm frustrated, I can use the words that I need to be able to use to develop that. If I can have common language with mom and grandmama and auntie and my early learning teacher, then I can develop a common language around supporting the child. We are beginning to see, as I said, some growth both in the reduction in negative interactions, the increase in positive interactions, but also an increase in their academic language.
And I can also speak to the data that I collected for my dissertation research that looked at the shift in how teachers were reporting the closeness of their relationships with their children before and after circle security. I had a control, 4 classrooms that were control group, 4 that were the intervention group. The teachers that had the circle security training increased significantly in how they were understanding children's behavior and how they rated their student-teacher relationship closeness with the children that had high adversity. And that was really important because these were children that in the control group, the teachers reported being less close to them at the end of the time because behaviorally they were a challenge. And so to be able to remove the barrier of the behavior and see the child has a need, these teachers made gains in how they saw the child and what their needs were. And I think data for GOSA is continuing to be collected and analyzed. I'm certainly not part of that piece of it, but those are the shifts and we're seeing.
Thank y'all so much. I do believe we could sit here and talk all day, just simply about your project and what you've done. And that's what I want to say is that study committees are sort of opening a door. So don't feel like all the things that you want to tell us that you haven't had the time to tell us, that door is closed. We will, whether individually or whether we come back together more, to ask more. Thank you for the work you're doing. You know, it's so important. We often want to tackle the world, but you have tackled what is there in your grasp to work with and to try to make it the best it can be for each and every child and parent. That parent is the key, no doubt. So thank you so much for the focused, intentional, productive work you're doing. I look forward to learning more about it.
Thank you.
Mm-hmm. And go home and do more, right? Yeah. So I'm kind of getting some signals here. We might need just a 5-minute break before we go back to before we come back, and we have a really important group to listen to again. So we'll be talking about Project Launch. Y'all, everybody, run take a quick 5-minute and run back. Okay? Thank you.
Like I said, early Head Start and Head Start runs
Robert Dick, nice to meet you.
important to cater for empathy, family, to shall produce
Well, how long you been back at Georgia? I had a good time Saturday. That was probably a good idea.
Everybody needed one. This is such intense information, too. I think we all have to kind of catch our breath and try to process it a little bit as well. So, next up, we're going to hear about Project Launch. Janine Galloway is the Maternal Child Health Division Director at the Department of Public Health, and Sharita Summerhour, the State Program Coordinator for Help Me Grow and Young Child Wellness Expert for Project Launch, which is a project at the Department of Public Health. And I want y'all to feel, as I've told everybody, feel you can stand there if you're more comfortable sitting down, whatever. Looks like you're in position, and we're going to get the right microphone on for you. Janine and Sharita will explain Project Launch, this 5-year federal initiative from the Substance Abuse and Mental Health Administration, SAMHSA. And the aim of which was to ensure the social, emotional, and behavioral health among children birth to age 8 and to promote safe, supportive, and nurturing families. Project Launch was piloted in Muskogee County, I believe, and allowed for collaborative efforts among child-serving agencies at the state and local level to increase screening, assessment, and referrals, and to increase that early identification of mental, behavioral, or developmental concerns in our youngest children. Yeah. Thank you so much for being here. We look forward to your presentation, and do not feel hurried. There's plenty of time.
Okay. Well, thank you so much, Representative Dempsey, and to the Social Emotional Study Committee. We are very happy to be here to be a part of this agenda to talk about the initiative of Project Launch. Again, I am Janine Galloway, the Maternal and Child Health Director at the Georgia Department of Public Health. I also want to mention before I go into this presentation that I will be back next month, so you'll get to see my face again, where I will be talking about maternal and child health programs, which includes home visiting, Babies Can't Wait, and Children's First. I know there were a couple of questions that I'm happy to answer today, but I do have a more in-depth presentation on those programs for next month as well. Okay, so Project Launch, we were very fortunate to have a 5-year cooperative agreement from SAMHSA, and we targeted Columbus, Muskogee County because of different rates that they were experiencing, unfortunately, negative rates when it comes to their health, especially the health of their children. And Project Launch was a true systems approach, and it was for all kids, all families, no matter your income level, race, gender. It was for all, a true public health intervention. And it was a systems approach where we included behavioral health and primary care, mental health consultation and early care and education, enhanced home visiting, family strengthening, and screening and assessment. And so this was systems integration that also include data evaluation, public awareness, and workforce development. We did a lot in this 5 years, but it was a lot of great work because we know truly to make an impact and a difference in the community, it has to be a systems approach. You have to work with the families, you have to work with the children, bring in the physicians, bring in the school system, bring in your community partners, and of course screen and identify kids early and get them in treatment as needed.
Good morning, everyone. My name is Sharita Summerhour, and again, I'm with the Department of Public Health, and I served as the Young Child Wellness Expert for the Launch Grant. So you guys learned previously about social emotional development the last time you guys met together. And through Project Launch, we initiated 5 prevention and promotion strategies. As Janine mentioned, the first couple are screening and assessment in a range of child-serving settings and mental health consultation. Our goal was to increase the awareness of Project Launch, which again is linking actions and unmet needs in children's health. We were also increasing the number of referrals to public health programs like BCW, C-FIRST, CMS, and our local home visiting program. And we provided outreach to physicians, to educators, communities, and families. Forgive me for being nervous. To do this work, we screened throughout family homes, we screened throughout the West Central Health District, and in elementary schools. For example, we partnered with our local Head Start to include screening tools like the SDQ within our screening assessment packets. So every single registration packet that went out to our early learning centers included the screening tool. We screened, we integrated this work, and what we did, we screened, and we supported parents by linking them with resources. Utilizing the Ages and Stages questionnaire, over the life of the 5-year grant, we screened more than 3,000 children, from ages 2 months to 5 years old, increasing access to early intervention. Through an MOU, which is an agreement with the local school district, Project Launch, mental health consultant was physically housed within the school system, where she provided services to both the teacher and the administrators. In year 3, 35 children received mental health consultation, and 80% of the members surveyed stated that the early childhood community, within the early childhood community, stated that Launch was important to increasing the use of emotional regulation strategies, reducing school expulsion rates, and challenging behaviors in the classroom. And I know that was a lot said, so I'm going to give you guys an opportunity for questions if you have any. Go ahead.
The 35 who were provided mental health consultation.
Yes.
Based upon the screening that it went to that level, or was that?
Absolutely.
Okay.
So out of those 3,000 children screened, our mental health consultant was able to provide 35 children within that classroom setting direct mental health consultation services.
So the 35, was that how many needed it, or was that just how many they were able to do?
That's how many were serviced through the Project Launch grant. Now, we partnered on this work with Project Aware, which were also in that school system, so some of those families were also serviced through Project Aware.
Okay, thank you.
And I'll just add to, Sharita did an excellent job with this work. It was a huge collaborative, but that was a huge success to get an agreement with the school district. So we partnered with our West Central Health District. You all know we have 18 public health districts in Georgia. West Central Health District is one in Columbus. We helped them form an agreement with the Columbus School District, where in those pre-K packets, there was a developmental screening tool included, which was the Ages and Stages questionnaire, which you all know helps to identify any risk that a child may have early. And so that's the first time that we know that that's been done in the state, where you had this opportunity to have a mass screening within the school system and really catch kids that could potentially fall through the cracks. And the impetus behind this was what we were hearing a lot from our early child care centers, some challenges, and then also looking at the school system and looking at their expulsion rate and some challenges they were having. The school system was a part of this work too. And so we also noticed that, screening wasn't done in the early child care centers, which we eventually got there to do those screenings there as well. But how great it would be to screen those children with the parents' consent before they entered school. And we were actually able to capture some kids and families that needed our assistance.
I will add really quickly that we worked with Brooks Publishing to provide the screening trainings to all the pre-K programs, as well as to some physicians, and we'll talk about that a little bit later. Our next strategy is integration of behavioral health into primary care, and our goal here was to increase the awareness of Project Launch amongst primary care physicians who provided pediatric care and referrals to public health services. Through a strategic partnership with the Georgia American Academy of Pediatrics, we launched a very successful physician outreach campaign where we hosted 10 workshops. We had 108 attendees, and all of these attendees reported referring into the West Central Health District's child health programs. 100% of our workshop and grand rounds attendees reported referring families to local health district child health programs. And what that means is that now our pediatricians are not only filling out the maternal child health assessment, but they're physically referring into our C-FIRST program now, which is our central point of access for child health services for the Department of Public Health. And previously in screenings, we found out that that was an issue. So when pediatricians would talk to their family members, they would say, you need BCW or you need CMS. Now they're referring to C-FIRST and allowing that triage process to happen so that families don't have false setups on what their children's needs are, and we're able to service them in that way. So that was definitely a great success of our physician outreach campaign.
Sure, and so I'll also add there, we know in public health we can't do it by ourselves. We need our partners, especially the physician community, and we have a great relationship with the chapter of American Academy of Pediatrics, and so we brought them on board to do these lunch and learns for the physicians and to educate them on how to refer into public health, what does our Children's First, our See First form look like, the importance of it, and that when you refer into See First, there, our See First coordinators will do that home visit. They'll also do a developmental screen if one wasn't completed by the medical home. If one was completed by the physician, we'll ask for a copy. And from there, we'll determine if that child needs to go to Babies Can't Wait, Part C, if that family needs to go to home visiting, if that child needs to go to our Children's Medical Services program, and also if they need to be referred to WIC, if they need to be referred to any of our community partners as well, quality rated daycare, behavioral health services, things of that nature. So that is a great triage point. So we were very successful to getting all of our physicians on board in Columbus, because that is really truly needed in order to really make sure we're getting those kids in as early as possible. Okay, next, the third part of our 5 strategies was evidence-based home visiting. And this we did enhanced evidence-based home visiting, where we focused on social emotional health. And I know this morning we've heard about home visiting, we've heard See First does it, Babies Can't Wait does it, but the difference I'd like to say is that this is, again, evidence-based, meaning it is a model that has been developed that has shown that if you're certified in the model and you complete the model, that you will see evidence and data showing the impact of that on the children and family use service. So in Babies Can't Wait and See First, they may do 1 or 2 visits depending on the family's need. They have a particular reason why of going. In evidence-based home visiting, such as parents, as teachers, you're there with that mom and that family, could be up to 5 years depending on that model. And you're helping them with parent skills training. You're talking to them, you're doing various screening tools, such as the Edinburgh, which is our maternal depression screen that we use. There is a domestic violence screen that's used. And also it's talking about early language nutrition, reading to your baby, singing to your baby. We talk about smoking cessation. There's 19 performance measures we have to meet and report on. Our funder is HRSA, the Health Resource Services Administration. And so again, we have data. Those programs have been researched for years now, and there's data supporting the effectiveness of them. And so these home visitors are trained in the models. They're certified. They have to keep their certification up, and they are early child care professionals. And so I wanted to make that distinction, because a lot of times you will hear home visiting when we're discussing other programs, but this truly is a program in itself that does only home visiting. And so this program was for those families we identified with our highest need. And so we selected to do the Healthy Families Home Visiting Program, where moms come in prenatally, and they have a little bit of a window. If their baby is less than 6 months, they can enter the program as well. So it's a very intensive program in helping that mom get to her well woman visits. If she's having trouble with finding childcare, quality rated childcare, they will do that care coordination, helping find a medical home if there is no medical home, and different services. And then once that baby is born, talking to the mom about, and of course it's voluntary, so the mom selects to be in this program, and we go in as if we know you're a great parent, and we just want to give you the tools to be even a better parent. And so it's very supportive. It's a very close relationship that is made, a very trusting relationship. And again, it's just giving those skills, those tools that you need as a new mom, or even a seasoned mom, that you need that additional help. And we target at-risk families, so those families that may be living below the federal poverty limit, that may be teen moms, maybe have reports of child abuse and neglect. Evidence-based home visiting is also proven to reduce child abuse and neglect, and also reduce prematurity as well with our babies. And so, and we also look at parents that are in the military. They're also considered our at-risk as well. And so again, we were able to fund 1 home visitor through this Project Launch initiative. Their total caseload was 20, so they serviced 20 moms. And so 20 moms came into the program. Some came in prenatally, and some had children. So that's where you see that 12 children, 12 babies. And again, the maternal depression screen was done, and we were able to identify 3 moms who had scored positive for maternal depression, they were linked to a medical provider that could help them. In Columbus, we have a community service board called New Horizons that we have a great relationship with, that we were able to build that relationship, and they were able to assist with our families. And then also with our home visitors, we were able to provide trainings. So on social emotional trainings, we did the Stewart's Darkness to Light that was conducted by Children's Healthcare of Atlanta. Dr. Topple, I believe you came and did a training on social emotional health as well for our community. The 5 protective factors that strengthening families does. Dr. Pat Minish came and did that training. And we did a lot of training. One thing that we heard, and I don't think I mentioned that this work also was led and spearheaded by a council. So we were tasked in developing a local council made up of community partners to help drive this work and help us finalize what our strategic plan was. One thing that we heard loud and clear from our council was, we don't always want to send our families to Atlanta. We want to be able to keep our families in our community. We want to be able to provide services and tools for them. And so that's why we brought the trainings to them. We trained our home visitors, our early child care providers, our teachers, our educators, again, to be able to keep it and build sustainability. So you didn't always have to have somebody to come in. We had trainers that we trained to then train the new people coming into the community. So this was truly successful, this home visiting program, and one that will continue. We've embedded it within our district, and also the University of Georgia Extension Services provides home visiting as well in Columbus. Lastly, we provided family strengthening and parent skills training specifically for our parents. So we did the World Cafe model, where we had a World Cafe trainer come in and lead sessions. You know, with this, you never know how families are going to take or if they want to participate or not. But we advertise this within our libraries, within our health department, within our community partners that are part of that council. We got 234 parents who we were excited about that wanted to be engaged and participated and came to these sessions. And then they would help drive what the future topics would be at these parent cafes. 150 children were in attendance. Again, the various topics were, what do you do when your child is misbehaving? You know, some people want to spank. Some people want to put the child in a corner. So what do you do? What is the right thing to do? So we talked about that. We talked about what to do in stressful situations. We all experience stress, no matter who you are. And how does your child feel when you're in stressful and lashing out? And how does that impact the child? And so we had a lot of great topics there. Also with our family strengthening, we had a parent partner. So we partner with Parent to Parent organization, and they provided a parent partner, and this young lady has a child with special needs. And parent partners are really for those families who have kids that are diagnosed with special needs. They know what it means because they have a child. They give that one-on-one support. They help them navigate the healthcare system. And so we were able to have one within the West Central Health District, and happily, after the grant, we're in the last of our 5 years. So we were able to embed this parent partner within our West Central Health District, and they were able to incur the cost of the parent partner. So that was a success. And then lastly, we had a leadership academy where we train partners on key leadership skills. So that was that next step after the parent cafes, was how do we help these parents then become leaders in their community? Help them to, say, hey, we have an issue with this way that the healthcare system is, or with public health, or with our partners, because we're experiencing it. And so how can you be a leader in sharing those and be a part of the change that you want within your community? And also bringing other parents in. And so we had a great session. The mayor came and spoke to the families. And again, it was a place where they could have their voices heard. And for a minute, I want to go back to that council, because our parents were also involved in our local council. We had it once a month. The police department was a part of it, the school system, quality rated daycare, YMCA, our physicians were a part of it, you name it, they were there, because recognized some of the problems they were having from the police department. They don't like being called, of course, to school when a child is misbehaving and they have to put them in handcuffs. And, we know that there's something going on with that child. It's not that they just want to be bad. It's something that wasn't recognized early. So we talk about that. We educate the police department on that, how to handle those situations, and talking with the families and how to refer them to the appropriate services. And again, our principal of our school system had an aha moment at our council. He said, at first I wasn't sure why I needed to be here because you're focusing on young children, but then I realized these are the same kids that will be coming into my school. So if I'm not a part of it and we're not making a difference early, I'm going to have these issues later, and we're not going to know how to deal with it. So that was really great for him to have that experience and for everybody to come together to work towards this. And then lastly, I do want to say we had a state council too. And our state council was made up of myself and our state partners, a lot that are here, our community partners, American Academy of Pediatrics, DECAL, DOE, the mental health organizations, to talk about what was happening in Columbus, but then how do we take those best practices and implement them across the state? What are our next steps here? Because we really, truly made an impact in the area, and we want to take these back. We want to talk about Department of Early Care and Learning, about doing developmental screenings potentially in early child care. What does it look like to do developmental screening within the school system? How to implement these parent trainings throughout the community, how to potentially expand home visiting. We know it's work, we know it's important. And so that's why we created that state council to help guide state impact work. And another great thing, and I'll end with this unless Sharita has some last things to say, was it was wonderful to have this grant within public health because the families we reach become our families, and we capture that data in our system. So we're able to track that family now. They've entered our system, they've completed our referral, did the developmental screening, they were referred into Children's First and potentially into Babies Can't Wait, and we can follow to see how well that family does, and then we'll do that warm handoff into the school system, into Part B services, and that family will continue to receive the services they need. So we were very fortunate for public health to receive that, and again, to have that opportunity to provide those wraparound services and to be able to collect the data. And again, Sharita, did you have any?
No, I think that's great. I would just add that one of the definite benefits to Project Launch was, again, closing that feedback loop. We closed the feedback loop with the pediatricians, with our families, in the school system. That was definitely something that was unique to the work that we're doing in Columbus, and it was very beneficial to families.
And again, we identified kids early, doing developmental screening. We partnered, we created that awareness of what kids 0 to 8. We provided parenting training for our parents, brought in mental health consultation, focused on social emotional, and brought in our physician community as well. Mm-hmm. And so again, thank you so much for this opportunity.
Thank you. And very thought-provoking. I know we already have one question, so let me start right now with Representative Oliver.
This agenda is very helpful in that we have a program in Clark County that is initiated basically by the school system or parent, created through relationships at school, and you come to the same set of children through the public health leadership. They had a GOSA grant that helped them get started. Is Project Launch a state money grant or a federal grant? You referred to HRSA, and I was trying to remember whether that is a federal entity or a state entity.
It's a federal. We were federally funded by the Substance Abuse and Mental Health Services Administration for agency. And so, yes, it was a 5-year grant, and it ends this year.
A federal 5-year grant?
Yes.
And were there other similar federal grants in Georgia other than Muskogee Grant that came with a similar kind of programmatical focus?
So there was Project Aware, and forgive me, I forget what Aware stands for, but that was with the Department of Education. Georgia was the only state that received 2. So Project Aware was for the older children, and where we focused on the younger children. But to my understanding, that there may be other smaller, other grants that organizations have received, but that was the first for the Department of Public Health for us to be able to do this type of work.
And what is Muskogee going to do to pick up this work if the federal grant is gone?
Yeah, so we worked really hard. We put sustainability in year one, sustainability planning, tasked our council with helping us with that. So the council will continue. Is it Healthy People? Healthy, no, 2020.
Oh,
Healthy
Columbus
Columbus.
2020.
Columbus 2020, which has similar goals that we did, will be assisting with the council. And we also received, Public Health received a Healthy Start grant, which is going to be doing some similar work in Columbus. We'll be using that collaborative. Within our mental health consultation, we partnered again with New Horizons, the Community Service Board, and they've agreed to continue to provide services where they can and be a partner there. And was there any other areas?
So similarly with our family engagement work, our partners through Columbus 2020, Healthy Start, our other local partners who took up that work, who did the Let's Read Muskogee work, they're all picking that up. So all of our partners are participating and making sure that we're able to continue to deliver these books and to be engrossed in our community. So again, a lot of this work was based in our local councils, and we are champions for them.
So yes, a lot of it. We did not want to just come in and start and then leave and then everything ends. So we worked really hard to kind of go to different partners and say, hey, you have the same mission, same goal. Could you take up one of the strategies up? And with the physician work, they're going to continue. They're not going to stop. It's nothing that we have funded there with the physicians. But they've made it a part of their habit in their normal day to refer into public health for services.
Well, thank you. I don't see any other questions or comments right now.
Sure.
There may be some as we reflect upon it a little bit later, but thank you. I think some of the greatest efforts has been proven. There's evidence there to show, I would say, that local community support, whatever the entity may be, is truly how it does sustain itself. So thank you for doing that from the very beginning and the work that you have and will continue to do.
And did you want me to answer any questions right now related to home visiting or Babies Can't Wait?
I don't see any right. Is there anything about Babies Can't Wait, or we'll wait till, we'll wait till you're back, and thank you for committing that. To the committee, you'll see that several of our experts reappear because they are so expert in so many very specific places. So thank you for that. Okay, we have another program before we take a little break for lunch to process this again and take a little break. And I want to make sure that our speakers know also that you're invited to have lunch with us as well. So some conversations may take place at that time. We're going to look at Chris 180's SAMHSA grant as well, a funded pilot program. Kathy Bragg is with us today, licensed clinical social worker from Chris 180, and we'll be seeing and learning more about Chris 180 a little bit later. Like we're saying, in another meeting, we'll have a little more of that. So the program director specifically for infant and early childhood mental health, currently operating in DeKalb, Gwinnett, and Fulton. And this program works with children and their families who receive assessment, intervention, and treatment. Also involved in the training of child care providers to more adequately handle social, emotional issues in the classroom. And Kathy was actually trained by Judge Peggy Walker's initiative, too, who we heard from last time. So I look forward to you explaining some of the need for the spectrum of services, which include, as we've been talking about, prevention, assessment, intervention, and treatment. Thank you so much for being with us today, Kathy. Let me get your microphone. Okay, there we go.
And thank you for giving me the opportunity to speak with you. I am so excited about the program that we have at Chris 180. First of all, this is a 5-year SAMHSA grant. This is year 1 that we're in, so we're at the very beginning, really trying to make a difference in the communities that we're working with. We are structured around Fulton County, Gwinnett County, and DeKalb County. And our target ages are 0 to 12 years of age. And our team, I want to talk a little bit about the structure of our team. Our team consists of a therapist trainer, a therapist, all of which are licensed professional counselors. We have a behavior aide, and that is a person who works in the classroom. And then we have a registered nurse who works with us. And the reason that we took that approach to have a nurse, because oftentimes people say, what is the nurse doing? Really to look at the developmental stages of a child, as well as making sure that they're up to date in terms of immunizations and all their health needs. We have a kind of a two-prong approach that we've taken in terms of our grant. We're looking at training any educator who has a touch with the child between the ages of 0 and 12. So that's that early childhood educator, that's that elementary educator, that's that administrators who are working with the family workers, advocates, anyone who's working with that age group. So we provide training. The training that we provide is specifically trauma related. And it is trauma related because we recognize, just as we've heard this morning and at the last session, that we know that the social emotional needs of children and how early trauma is impacted and how it presents in so many different ways that oftentimes the teachers who are there with the children don't really understand. So we recognize the fact that it was really important to train those teachers to be able to understand trauma and how it presents very early on, and then also to give them the tools in terms of some kind of basic, simple, practical strategies that they could use in their classrooms to create an environment that can support that child. Excuse me, but not only the child who has been identified as having some social emotional issues, but also any child that's in that classroom, so that the classroom has that environment that's very supportive of every child in there. We also know that trauma looks different for children than it does for adults. And one of the things we really try to talk about in the training is brain development, which you've heard a lot about. Dr. Tracy talked extensively about the brain and how it presents itself and how wonderful that brain is and how quickly the brain potential can be destroyed because of the constant exposure to trauma. But the good thing is it can be repaired. And so that's what we really try to train the teachers in, the fact that, yes, you may see this behavior, but if we put certain things in place, if we give you the tools that you need to really understand what's going on with this child, then you'll be able to support this child and also support the family. So the other piece of what we do, we provide wraparound services. And what that looks like is very intense services for families. But it's just not for the family. It's for every system that touches that family's life. So whether it's DFACS, whether it's juvenile court, whether it's the school, whether it's public health, whether it's the neighbor, anyone can be part of that team to support that family. And we really look at natural supports. We look at whether or not if they want to bring a minister to their treatment team meetings, if they want that neighbor to be there with them, because it's really important for the family to see that this is not anything that is so humongous that can't be changed. But in fact, with the proper supports, that things can happen and things can really change. Our wraparound is very deliberately designed to address the families where they are. So for example, we don't necessarily encourage families to come into the office. We know that transportation is an issue. We know that finances are an issue. So we're able to provide those services in home, in the school, anywhere they want to meet, we will meet them because we want to make sure that we're in their community and we're addressing their needs the best way we can within the systems that they can afford. One of the things that we do that's kind of, I think, unique is the fact that we add our parent-child psychotherapy. And I know Judge Walker probably gave you an earful about the work that's being done in Douglas County and her commitment to early childhood and how she really advocated for therapists to be trained in parent-child psychotherapy. And I was fortunate enough to be part of that cohort that was trained. And I think that when you sit around and you look at all the different needs of children, and it's so easy, I think, for mental health professionals to really just want to look at the identified person. So, you know, the parent comes and says, fix my child. But in parent-child psychotherapy, we're working with the parent and the child. We have them in the room. So it's even different than play therapy, because play therapy, you have the therapist working with the child, which is wonderful. However, the child has a relationship with the therapist. With parent-child psychotherapy, we're trying to increase and support and engage the parent and the child to have a relationship. Because that's important. We leave, that parent has that child. The child has the parent. So it's important for them to be able to have a relationship with one another, to be able to understand those cues. What does the child need? How do I respond the most effectively to address the child's need? And how do I address my own needs as a parent? And again, we heard some of this earlier in terms of some of the other presenters, but I can't say it enough that is really important around attachment and relationships. You know, we have children, you bring them home. I don't care how many books you read, the real thing is the real thing. And so for a lot of parents, it's really, how do I see this person, everybody thinks I should be happy that I have this child, and part of me is happy, but the other part is me really overwhelmed. I don't really know what to do. So we also use Circle of Security. We realize that that is something that is really needed for families, as you heard with the other presenters, but we also use that at Chris 180. And we have trained facilitators to be able to roll out Circle of Security. And I really want to talk a little bit about workforce development. The reason that we really look at training those teachers, because in early childhood, we realize that there's such a turnover in terms of teachers. And one of the things we recognize is that children need consistency. So if we're able to give the teachers what they need to be able to stay in those classrooms and to be supportive and nurturing to those children, then we need to do that. And it's very hard to do that because we don't have a lot of providers, clinical providers, to be able to train teachers on what to look for, how to look for it, how to have those hard conversations with parents. Because we can have all these services, but the parents aren't really I don't want to say not willing, but just not sure about what it is that their children need. So we really have to teach teachers how to have those conversations about, you know what, there is a resource that we can provide for you, free of charge. Doesn't have to worry about your income. No, doesn't really have to worry about if you in that area, the county that you live in, and that's the county that we support, you can get those services. So we really try to encourage teachers to hang in there and to get the skills that they need so they can be the best that they can be. And the same thing with child-parent psychotherapy. I don't know whether or not Judge Walker told you, but she got funding to be able to do that. So even when you look at the programs that are using Circle of Security, one of the things I heard them say is that they still are missing, there's a missing link. They don't have that clinical person to be able to do that. And that's where the child-parent psychotherapy comes into play. But it also is very costly to be able to train, and it's lengthy. It's not just one and done. It's an 18-month commitment for the therapist and the provider and whoever is paying for that. At Chris 180, we have, in our grant, we were able to have the money to be able to train our therapists on child-parent psychotherapy, on Circle of Security. But those things cost, and had we not had the resources from SAMHSA, we would see it, we would know that it's there, but we would not be able to address it appropriately. And that's the unfortunate thing, is because it's kind of like, you see the train coming and you don't get off the track. You wait till something happens and then you act. And we really recognize the fact that we have to do something before things happen. Because I think the last presenter said that you see them in high school, you see them in elementary school, you see them in middle school. We need to be able to help that mom, recognize that depression that impacts on the children. The child that she brings in, if she's depressed, she's not going to have the same response that we saw in Tracy's presentation with the mom engaging with the child and they're laughing and they're responding to each other. If she's depressed, she can't get out the bed, she's barely just feeding this baby. That baby is not getting what he or she needs at the very beginning. So we really need to be able to understand the importance of investing in our future in Georgia and investing in the welfare of all staff development, all families. With our program, I see parents who are in Sandy Springs, so they don't have financial concerns. They're not saying, oh, I'm going to be living in a hotel. I don't have food. I don't have the basic necessities. They have what they need in terms of from a financial situation, but they are still struggling with children who are struggling because of whether it's divorce, it's separation, it's car accidents, it's the smallest thing that we may think that, okay, I'm over it because I'm an adult and I know how to handle it. That child is still struggling with something. And so, as again, I have the families in Sandy Springs and I have the families that in South Fulton living in a hotel. So my hope is that you recognize the importance of it's not a racial issue, it's not a economic issue, it is across the board and it's across the country that we are seeing more and more young children that are impacted by trauma, whether it's listening to the news or being in a car accident or having out-of-home placement because of foster care, living in a hotel, experiencing a home fire, a shooting in their community, something that they hear on television. It impacts all of them in all ways. So I really want you to know that we're working hard at Chris 180 to really make a difference in the state of Georgia. Our hope is that, I'm a visionary, and so I'm hoping that we will be able to spread the wealth across the state because I know that it's needed, and I believe that people like yourselves really believe in this work and want to do what's best for all families. And hopefully we will be making some significant impacts within the state, particularly in the areas that we're in now. And this, like I said, this is our first year. I can tell you right now, between the months of May and August, we trained 407 teachers. And that was with Sheltering Arms, the YMCA, and also some other independent centers. We have partners. YMCA is our partner, as well as Sheltering Arms. So we are, and because I really believe in partnership and looking at sustainability, even though we're in year one, I'm really being able to tap into other providers who are interested in this work to be able to say, okay, what can we do to support the work that you're doing? And let me share what we're doing with at the work we're doing at Chris to be able to make a difference. So does anybody have any questions? Because I could go on and on because I'm very passionate about this.
Thank you for that passion, too. And for the work that you've done, like you say, very quickly in this first year. That's a huge commitment to get up and get going, and especially at the level at which you have decided to do. I know you are impacting and changing lives. Are there any comments or questions at this point from our panel here? No, so I think we're going to be thinking about them, and we'll be saving them all for when we are with you again. But
Yes.
I want to ask you to, join us for lunch, and there maybe if you're available, and we'll have some sort of more relaxed time to talk, just a little bit briefly though.
Okay.
So at this point, this concludes our morning session. We're going to go kind of process what we've all kind of wrapped our arms around today, and come back at 1:30 for another important, a couple of presentations, and then time also for public comment and discussion after that.
Do you want to make that a little earlier than 1:30?
What time? I'm not even paying attention to the
12:20.
It is
Come back
12:20.
at 1 maybe?
Well, we could if our speakers are here and with us and able to, and we'll see if they are both can be here at 1:15. Is that what you want to shoot for? 1:15, and we'll. Yeah. Is that okay? Great. Thank you. We'll start that way then at 1:15. Thank you, Representative Oliver. Good to be back with y'all. So we are going to have one last speaker. I understand there was a second that might have had something come up, but we have really special Donna Davison, the CEO of Easter Seals, here to speak to us about the specific approaches to prevention through the lens of Head Start and home visiting, I believe. I had the privilege of visiting with Donna not too long ago and hearing about a great deal of the work that she does as the leader, basically, with Easter Seals of North Georgia. She operates 11 inclusive child care programs serving nearly 2,000 children and their families annually. 90% of those children and families live below the poverty level. And Easter Seals administers Babies Can't Wait for children with disabilities. Nearly 800 infants and toddlers with disabilities receive services in their natural environments. We've heard about that this morning. So in their home or their school or wherever best to reach their needs through this program. She is truly very passionate. I heard her, and I know what a great advantage it will be to us to hear from you today, to hear you talk about infant and early childhood mental health and implementing the incredible years in the program. So I just want to let you take the time now and help us get smarter.
Thank you very much, Representative, for allowing me the opportunity to speak to all of you. And I cannot tell you how excited I am that this study committee has come into place, because for the last 17 years, I've been talking to anybody and everybody that would listen to me about a moment about the fact that we were missing what was a very incredible thing that we were seeing in our programs, which was the social emotional well-being of our youngest children. So Easter Seals is a national nonprofit organization. We are celebrating our 100th year anniversary. So we have been around for a very long time. Easter Seals North Georgia covers 44 counties, including Metro Atlanta, and those counties northeast and west. I'm going to speak specifically to two of our programs, our early education and care program and our early intervention Babies Can't Wait program, and what we see in terms of infant, toddler, early mental health, early childhood mental health. Easter Seals is a very large provider of Head Start, early Head Start, and Georgia pre-K programs. Through that particular program, we provide comprehensive services, which includes medical, dental, social, emotional, disability, nutrition, and family support services. As part of that, all Head Start programs within 45 days of enrollment have to deliver a developmental screening to children, a social emotional screening, vision and hearing screenings, and a home visit. After 60 days, every single child in the program has an individually developed education plan. And within 90 days, all children must have a physical, a dental exam, and a family partnership agreement. And this is something that's true regardless of where your Head Start or early Head Start program may be. In our Head Start, Early Head Start program, we are serving 1,523 children in 14 locations in 6 counties, and those counties are Fulton, Gwinnett, Barrow, Jackson, Walton, and Madison counties. 100% of the children in that program are living at 100% of the federal poverty level. And if you're not familiar about what that means that a family of 4 is living on approximately $25,000. So we're really taking really children that are really living in dire straits from a poverty perspective. 30% of the children in our program have some type of a disability. 11% of the children have other health problems such as asthma, anemia, high lead levels, or diabetes that need to be followed. And when we looked at the children within our program, just about 100% of those children have 4 or more adverse childhood experiences that are compared to on the ACEs study, which puts them at significant risk for future health and social and behavioral programs. I looked at the last 3 years, and between 14 to 16% of our children require mental health services. So 14 to 16% of that 1523 require some type of mental health intervention in that program. And that's pretty typical about what the averages were showing, between 9 and 14% of our young ones across the country. If you look at our population, about 70% of our parents are single moms. 70% of those single moms are working. Last year, 17% of our families received services to address mental health challenges. That's in addition to the 16% of the children that needed those services. And 32% of our families each year require emergency or crisis-directed services that could be related to domestic violence, substance abuse, or legal issues. So from just the description that I tell you, you can see that our little ones are really exposed to a lot of risk factors at every single day that they go through. And this is a typo. It was actually 2002, not 2005. We started to notice with our kiddos an increasing number of children presenting social emotional challenges. And with the babies, what we were seeing was many infants and toddlers who were being diagnosed with failure to thrive. A lot of babies having significant gastrointestinal issues. Some babies who are on one end of the spectrum who are constantly crying, and on the other end of the spectrum who are very listless and quiet. As I went out into the community to figure out what is it that we're seeing here, a well-known psychiatrist said, Donna, you know, a baby's stomach is essentially their second brain. So it's telling us that something is going on. And then with the 3 and 4-year-olds, we were seeing lots of behavior problems. Believe it or not, we were even seeing gang-type behaviors amongst some of our 3-year-olds. And it was becoming increasingly difficult to keep them in a class of 17 or 20 children. When we went out into the community in 2002, we could not find any community partners that were serving children under the age of 5 for these issues. And so because as part of Head Start, Early Head Start mandate that we address the social emotional issues of the kiddos in our program, we had to find a solution that would work for us. What we knew going in, and you've heard that over and over, is that young children's social emotional development, influence every single critical developmental task of the first 5 years, whether it's physical or cognitive or linguistic or social emotional. We also know that significant adversity in early childhood, including trauma, abuse, living with a parent with a substance abuse disorder, or being raised in persistent poverty, can cause toxic stress, which disrupts a young child's brain circuitry. And we also know that supportive relationships, and you've heard that earlier today, and positive learning experiences begin at home, but they can also be provided through a wide range of services with proven effectiveness. And we also know that intervening as early as possible is critical to determining the best outcomes. So when we looked around, we knew that we had to develop a comprehensive set of services that were going to be designed to promote healthy and social emotional development among children and families enrolled in our Early Head Start, our Head Start, and our Georgia Pre-K program. So our comprehensive program, first of all, provides early identification through screening. We administer the ASQ as well as the ASQ-SE, which is the social emotional assessment. We needed to conduct follow-up assessments with those that we identified through screening. And then we needed to put together a tiered program to help at all levels for this program. At that particular time when we were looking, the Incredible Years program was the program that was most being used, although it was not being used very much on the East Coast. It was being used internationally and quite a bit on the West Coast. It was started out of out of the state of Washington. That program and the modules that we chose to use were several different steps. We used, from a prevention model, the Incredible Years Attentive Parenting Program. And then from an intervention model, we utilized the Incredible Years Small Group Treatment Program. We also use Second Steps supplemental curriculum, and we have recently been trained in the last 3 years through DECAL on the pyramid model and PBIS. Now, all of those are evidence-based programs. You heard about the Circle of Security beforehand. I think what's critical is there are many programs now to choose from, but what's critical is that they should all be evidence-based. This particular program is designed to promote emotional and social competence and is designed to prevent, reduce, and treat aggression and emotional problems in young children from ages 0 to 12 years. The Incredible Years program has been given designations such as exemplary, promising, proven, and model in review groups such as OJJDP, SAMHSA, NREPP, Promising Practice Networks, Blueprints for Healthy Youth Development, and the United Nations Office on Drugs and Crime. We started at the very basic level by giving all of our teachers a full year of training on everything from how to structure a healthy, nurturing environment within the classroom to also looking at, so what do you do when these behaviors erupt in your classroom? With the kiddos that we identified as needing some more intervention and treatment, they actually go to what we call dinosaur school. And we utilize big puppets as part of the program. The program lasts for about 18 weeks of length, and it's small group treatment for the children to work with that are having these issues. We have another component where we brought the parents in of the children who were in this program, and we also offered small group treatment to the parents. Now, we have a cohort of 6 staff members that work through this program. One that heads up the program is a licensed professional counselor. We also have a licensed medical social worker, and we have a couple of other folks that are going through their licensing certification for this. As with the other folks that spoke to you about this, we did not have funding to deliver this program. The Head Start and Early Head Start model does not allow for this kind of funding to be able to initiate this kind of project in depth. So we were able to receive the early seed money for a 3-year private grant in Georgia. And that got us going, and then every year we write multiple grants to try to keep this program going. As everybody can attest, and what you heard is that it's great that we can get a SAMHSA grant or another grant to start things off, but we must have a system in place that's going to continue this work after that seed money kind of goes away. This is just a little bit of a picture of the Incredible Years program. The reason why we really like this program is that it does not require licensed counselors at every single step of the pyramid. And so at the bottom level, where you're doing sort of the universal prevention and promotion, you can use child care teachers, you can use parents that are trained, and this whole program actually has a certification module embedded right in with it. And then as you go up the certain levels, then you need at the top of the level where you're getting into those kids that really have had the diagnosis, really more the psychologists and the therapists at that particular level. And stop me if you have any questions along the way.
Sure.
Can I ask?
Excuse me, and Madam Chairman, I hope I don't get in the weeds here. I'm a numbers guy sometimes, talking about cost. We got other providers of throughout the state, but you're talking about another program in addition on top of it, and you talked about getting the grants to fund it. How much more money is that per student or per facility, or I mean, is it? Give me a little bit of a what we're talking about.
So when we got the first grant to do this, we received a 3-year grant in the amount of $500,000 to get us going. And, you know, so we have to look for those funds every year to keep us going, and that's not an easy thing. And you know, your biggest cost is in the cost of your staff.
Yeah.
That's really what it is, being able to have those professionals in place to carry out the work that we have. Because right now, and you'll also see when we also administer the Babies Can't Wait program for Gwinnett, Newton, and Rockdale counties. And that is not, social emotional treatment is not one of the services we provide under Babies Can't Wait. So there really isn't any other mechanism for us to build to for the delivery of those services.
Thank you.
Did you have a question?
Representative Oliver, please.
I think I've been told this is something, somebody's going to explain this to me this in the future, but Babies Can't Wait does not provide social emotional services because you need a diagnosis for a child, and 2, there is no Medicaid funding for that.
Correct.
Am I right on both?
Yes. Now, there are many Part C programs in other states that do provide those services. But remember, this whole area is relatively new, so to speak, and there really isn't a financial mechanism. And in Georgia, I can tell you that the Babies Can't Wait program is very underfunded. And so there would never be any money to be able to supply those services on top of the others. But usually what ends up happening within the Babies Can't Wait is a lot of those services that are covered would fall under those EPSDT covered services.
Of specific diagnosis.
Right.
Identified under EPSD screening.
Right. We can also, and we do quite liberally, utilize observation for children to get qualified for the program. Now, you don't have to come in with a diagnosis, but what happens is if you come through the Babies Can't Wait program and we determine, let's say, speech and language, that there is a need, then we need a physician's order to be able to get that reimbursed through Medicaid or private insurance or whomever. So that's how it works. What we are doing in Babies Can't Wait, and we've just begun in the last couple of years, is to provide treatment to children with a diagnosis of autism, and we were able to get that applied behavioral analysis funding. But again, the child has to have a diagnosis of autism for that to kick in. Okay. Because we have been doing this program for 17 years, we have 17 years of data that we have collected, and some of the tools that we use to assess this program is the DECA, which is the Devereaux Early Childhood Assessment. Within the incredible years, there are several assessment tools, such as group leaders evaluation, Wally's problem solving test, parent satisfaction surveys, and teacher satisfaction surveys. We really use the results of the DECA because one of the things that we are trying to do is build resilience in our little ones. Unfortunately, we can't take away all of those risk factors that come along with living in low poverty, but we are trying to build the resilience of the children in the program. And so what we have found over the last 17 years is that at our initial DECA assessment for those kids who need the treatment, 66% of those children, have to improve their total protective factors overall. which is really giving an overall indication of their strengths related to resilience. High scores on this scale are associated with children who are functioning well in preschool and other environments. By the end of our treatment, what we notice is now 66% of those same children have shown the total protective factors as typical or as a strength, with only 34% still showing this as an area of need. Now, within those total protective factors, what we look at are initiative, attachment or relationships, self-regulation, and behavioral concerns. And we see the greatest gains in attachment and in self-regulation, which is really critical. So what this is telling us is that the program that we've been implementing, and we see very, very similar results from one year to the next over the 17 years that the program is working. One of the biggest challenges associated with this program is getting the parents to participate. And we have to be very, very careful. We cannot use the word training. We have to ensure that we have a very well-developed relationship with our parents. Many of our parents have had difficulty in school. They're school dropouts. They haven't have had a lot of positive interactions with folks that they can consider to be authority figures. And so we really have approached this as participating in parent cafes, and it's an opportunity where parents can get together, talk amongst themselves with a facilitator leading this. But you know, we spoke about relationships. It's really relationships at all levels. And those parents have to feel that they can trust us. You know, they don't want to feel, oh gosh, is DFACS going to be on my doorstep next because you don't think I'm doing, you know, the right thing. So that's been really, really critical. I think we could even be having more positive impact if we could get all of our parents, you know, sometimes it's the ones that don't need to participate that participate. If we could get all of them really engaged in the program. But even outside of that, working with the children themselves in an environment where most kids are today, right? Most kids are in some kind of an early education program. We are really able to affect great change in not only our teachers in the workforce, but also in the kiddos themselves using this particular program. We also use the pyramid model, and the pyramid model shows you kind of the different tiers of intervention, right? So you start at the bottom, making sure you have an effective workforce, and that effective workforce is not just in your clinical providers. That's whomever is working with children. When Dr. Toppel was up here, she said it requires folks from all different sectors, and it really, really does. It's the physicians understanding the child development and social emotional development. It is the parent sector. It is the early education workforce understanding that. And then it goes up and down. So making sure that kids have nurturing and responsive relationships, high quality supportive environments. You know, if they are in early education all day, making sure those are healthy, supportive environments there. When they need targeted social emotional supports, having somebody that can consult with them to bring those supports. And if you do all of those bottom ends of the pyramid, hopefully we'll have very few kids that then require those intensive interventions at that top of that pyramid. We were talking about this earlier, and we're very grateful to be a Head Start provider. And as we said earlier, there are only 24,000 children enrolled in Head Start across the state. There's another 4,800 children in early Head Start. But in Georgia, we have 657,414 children who are aged 0 to 4. And we have 178,000 children 0 to 5 who are living at 100% of the poverty level. So we have 178,000 children that would qualify for Head Start and Early Head Start for essentially 28,000 slots. So that speaks to what happens to those other 150,000 children that probably have 3 or 4 of those risk factors. When Dr. Topple spoke, she said hers had 3 or more, ours have 4 or more, and I'm sure that's pretty common amongst children living within the socioeconomic level. So we're missing a lot of kids. We also administer the Babies Can't Wait program, as I said to you. We're actually serving more than 2,000 children per year in just those 3 counties for children birth to 3. In our particular program, all children receive the MCHAT, which is the assessment that looks for children that may be on the autism scale, but it also picks up kids that have some behavioral issues going on as well. And then they come to us, and then we do a full evaluation. And as I said, if the kids don't have a diagnosis or they don't meet the 2 standard deviations below the mean, in our particular program, if there are a lot of observations that support the need for those services, those children will be accepted into the program and serve. We work very closely with Children's First. And to just tell you, they did, Children's First this past year did almost 5,000 ages and stages questionnaires. That's a lot of kiddos to touch over a 3-county area. Of those ASQs, 285 of them came from DFACS referrals. And that's another area that we haven't talked a lot about, but we know that there's a tremendously large percentage of children that are in foster care that are under the age of 5. And those children do not receive any social emotional screenings. They are what we call categorically eligible for Babies Can't Wait. But oftentimes what happens is if you have a 1-year-old that's just been put in foster care and they're referred to Babies Can't Wait to be screened, that ASQ is a caregiver-informed screening tool. So if the foster care mom or dad does not know that baby really well, you know, the child may go through and not be red flagged with any issues. And then that baby may be moved back to the home and then out of the home again, and then they're in a different county. And so it's really difficult to keep track of where they're going. So, you know, of those 286 kids that they screened, only 87 made it to us for further evaluation. So that there's that other group of children in foster care that we need to be very concerned about because they're being removed from the home, and I can bet you anything that there's attachment issues that are going on there. Yeah. So, and also in our early intervention program, all of our providers have been trained in the pyramid model and PBIS, as well as parents interacting with infants. In our program, we are approaching it from all different levels. So we are using many different evidence-based practice programs and trying to pull the best to provide the teachers, the staff, as well as the parents and the children with those systems that they need. You know, Dr. Topple talked earlier about sort of, you know, what was missing. And I will tell you that for those children who get to the top of our pyramid in the intervention model is where we're having a huge problem. It is almost impossible for us to find psychiatrists who will, who first of all have skills in working with children that young, and a bigger problem is who will accept Medicaid as payment. I won't tell you where, but we had a 3-year-old child who mom was schizophrenic, and the 3-year-old started presenting with some significant behavioral issues and other issues that looked beyond just behavior. There was obviously something clinically going on. My staff tried to find a psychiatrist to refer her to, and they didn't have any luck, so they called the boss. And I actually made personal phone calls to many psychiatrists to try to just get a favor to see this child, and could not find any care. So we finally found some place to take the child to, and one of my counselors accompanied the mom to the visit. And the visit was less than ideal, and then we were quite concerned because once the diagnosis came out, the treatment methodology for this was to put the 3-year-old on lithium. And we were a bit astounded with that. We are not psychiatrists, but we do know child development awfully well, and we know that a child's brain is still developing. And then to prescribe lithium and have a mom who is schizophrenic and not always taking her own meds to have to administer this medication was a little bit frightening for us. So that's a huge gap within our state. I do have a few recommendations before I wrap up. And, there have been a lot of questions that I've been listening in the audience, like, where does decal fit into this? Where does Babies Can't Wait fit into this? How about maternal child health? Where does Medicaid fit into this? This is not a one-stop place. This is going to require cross-agency leadership to address this problem, because every one of those agencies I just mentioned, including developmental disabilities and mental health department, they all have a role in this. And it is going to take getting them all in the room to work together to strategize about this. We don't have Medicaid payment for this. These services in Georgia, many states have already adopted this, and most states have approached it from early child mental health is and should be a covered service under EPSDT. So that's really where it fits. What is very interesting about Medicaid, in many states, Medicaid reimburses mental health services when it's treatment that is severe enough to require a psychologist or a psychiatrist. When you're talking about EPSDT, you're talking about, as part of that is not only the treatment, but also the prevention. And so as we look at Medicaid funding, we have to ensure that prevention is covered and treatment is covered. All of the models that you heard today don't have a sustainable funding model. None of us do. We are seeing the problems. We're treating these children every day. Easter Seals has a policy where we will not expel a child for a behavior. So we're the last stop shop for many kids. They've come to us after 4 or 5 child care centers have already expelled them at the ripe old age of 3 or 4. But the other early care programs don't have that capacity in place. They don't have those systems in place. Early education programs are not even required to do any developmental screenings in Georgia. So we're not even identifying kids with disabilities, never mind the behavioral issues. And usually what leads to an identification of those is because the child is disrupting the class and being expelled from the program. I think we have to look on an agreed upon set of core competencies for early childhood mental health. There is an association that's called the Alliance for the Advancement of Infant Mental Health. 30 states have a chapter of that association. We do not in Georgia. And they have developed a wonderful, wonderful system of core competencies amongst different levels. So if you're an early childhood educator, you can get a certain competency, like there might be a competency levels developed within DECAL. If you're working within early intervention, you can get another set of competencies, all the way up to the highest level, which is like a licensed professional counselor or a licensed medical social worker for working with those more involved kids. And that goes along with, we have to have a trained workforce at all levels. This goes along with it. Embedded is a primary support in quality rating and improvement services. There could be a special credential that the teachers could get into that system. And also embedded within a variety of programs serving children and families, such as early intervention and home visiting. I think right now when children under the age of 3 have an issue, they go through Child Find and they end up in early intervention. So that system is alive and well in Georgia. We just don't have the resources at this point to be able to provide those mental health services. That just wasn't one of the services. But there is a system in place for them to come in through us. I know in our program, we get referrals through physicians, we get referrals through parents, grandparents, etc. So the Child Find and the Children's First program is working quite well as a way to enter into the system. Those are all my recommendations and my comments. It's something that we've been working at for a long time. We're excited that it's risen to this committee for consideration, and we're excited and happy to help in any way that we can.
Thank you, Donna. Are there any questions or comments from the committee at this point? No, I thank you for sharing a good overview of the work that you're doing and the many, many lives that you are touching, children and families that need these services. So I thank you for that. I'm sure as we go forward, we may have some questions or want to talk again. So persevere. Thank you for the work you're doing. Appreciate it. Okay. So we have some time here. We have advertised public comment for 2:30, so I want to make sure we're still kind of around. Is there anyone here right now that wishes to come and speak that has not spoken to us today from the public? Okay, so no one's here right this minute. So I'd just love if there are any thoughts that any of you are having that you think it's a good time to share, or some things that you see that you'd like for us to investigate more, for us to start making that list for the next 3 meetings. We have a little bit of time here. We won't be coming back together till mid-October is the plan right now. So if there's some things you'd really like for us to find some more information out or have another presenter, if you would let us know now or when you think about it. You might.
I've got a question from the last presenter. Could you, I'm familiar with my Head Start program in my rural county, but could you talk a little bit about your providers for early Head Start? I'm not as familiar with your providers for that program.
Do you mean the teachers?
Well, that's teachers, the actual places, or it's not exclusively early Head Start, are they? Or are they
so
mixed?
in our location, so early Head Start is they're both federal programs.
Correct.
Early Head Start is for children birth to 3.
Correct.
And Head Start is for children 3 to 5. One of the primary sort of conditions for participation is at first looking at your income level. Mm-hmm. So the income level used for that is 100% of the poverty level, which we started from that. Early Head Start is done in different ways. Ours is all center-based. Some programs do home-based as well as center-based. But in our program, it's continuous. So the kids start with us at 6 weeks, and then they can stay with us till they're going off to kindergarten.
In the facility, is it you got 14 different
locations? 14 different
facilities.
facilities in 6 counties, yes.
So you have Early Head Start at the same facility?
Yes,
that
sir,
okay.
yes. Yes, some just have, it depends, it's very odd. They're 2 separate grants. So you could have a Head Start grant but not have an Early Head Start grant, or you could have an Early Head Start grant and not a Head Start grant, which is why they may not be at the same facilities. Does that answer?
Yeah, that's a little bit what I'm getting at. I'm just trying to get in my head.
Yes,
how these services provided for these.
Yeah, and there are
in
many
different
more
locations around our state. I know you got a great system up there, but not everywhere is quite.
No, it's not. And there are only, for the little ones, there are only 4,200 Early Head Start slots across the entire state. So we never know when expansion opportunities are going to come through. The last 2 years, there have been expansion opportunities. But Georgia really has not been funded the last 2 go-rounds. We don't know why, but we keep on, because even within the counties that we're in, we have huge waiting lists. So we're always looking to expand those opportunities. But it's a federal opportunity. You don't know when it's going to come down. And then you don't know, even at the end of the day, if you've scored really well on your proposal, how the decisions are going to be made and where those programs are going to be expanded to.
Is it a 5-year program, or is it yearly, or?
It's essentially, you're on a 5-year grant cycle, but essentially we are evaluated a tremendous amount. And as long as you're doing a good job and, at each of those evaluation points that you do well, you will continue the grant. We've been a grantee since 1997.
Okay.
Great.
Yeah, Ms. Davidson, I was going to ask you something. Thank you for being here today. Very helpful information. You mentioned an issue that's kind of near and dear to my heart as someone who serves on the boards of several nonprofits and has headed some nonprofits. Sustainability. You said there was no plan other than either, I don't want to put words in your mouth, but either continuing of receiving these grants. And I was in a program in Cobb County that we got one federal grant, and then we got another one, and then it went away, and we didn't have a plan, and the program shrunk to almost nothing.
Yeah.
Most of the nonprofits that I work with, they don't really have a sustainability plan either, except the generosity of the community in which they reside.
Exactly.
So my question is does the community participate in funding your program in any way at all, or is it strictly?
No, the community does. We have to do, just like every other nonprofit, we have to do fundraising. And fundraising is a challenge. And if you've run a nonprofit, you don't want to base your budget on that.
Well, fundraising that's the real F word at my house. All right.
It is. It's a real challenge. I mean, we can hope and pray that this event or that individual is going to give us whatever, but it's a difficult to put all of your eggs in that basket. So we have to use a whole bunch of different resources to sort of plug together. And even with the grants, some foundations want to fund the next shiny thing, and then they don't want to fund you again. It's that whole operating capital, which is why in this particular area, most states have had to develop an ongoing system to be able to fund these services.
And by that you mean the government, basically.
The government,
puts
yes.
in the budget,
and most of it, it starts with Medicaid,
right.
And then we go from there. If that's what's going to be needed.
Yeah. Okay. Thank you.
Great. Okay. Any other, just as we move forward, are there some things, I know we've talked about needing more information from Babies Can't Wait and some of the other programs that have been brought forward. Anything at all? From anyone? Y'all are just happy as clams, aren't you?
Just getting inundated with.
I know, it is quite overwhelming. So I will say, since we do have this little bit of time, I know some of us will be here some next week, or later this week. It seems like it's next week, but it's later this week. We'll all probably, we'll see each other more. If you think of some things that you'd like for us to dig into or find out some more information, there's a pretty robust program planned right now, but there's still room and space if we need to add anything or make sure that some of the presenters are particularly covering anything that you feel could fill in some of the gaps that you may find. Yes, Representative Oliver.
I'm aware that there has been litigation across the country in federal courts over states' compliance with EPSDT. What I don't know is what the status of that litigation is right now, 2019, and whether or not any court has ruled that early emotional development services are part of the mandated EPSDT guarantee. Somebody out there has access to legal research that can tell us to what extent EPSDT has been, which is a mandate for the hundreds, for all of our children under Medicaid, to what extent that the courts have defined EPSD to include certain mental health services that would overlap with emotional health.
Okay.
I don't know if there's been any litigation, but you know, the difficulty with EPSDT is that there's not a federal definition of what, you know, ameliorate or prevent means. And so what the folks that have litigated against whatever it is, and I'll just tell you, when I arrived in Georgia, we weren't even able to bill for physical, occupational, and speech therapy, and that's the route that we had to go through. And at the time, you know, the big dilemma was, okay, we were arguing over what does ameliorate mean, right? And there's not a federal definition of that. So I think anything that engages in the promotion and prevention and treatment of a young child is what is involved. So EPSTT goes across just that, it goes beyond the medical necessity, and that's the argument. Yeah.
What I'm interested in is who's been successful in making that argument enforced by any federal court across the country. Somebody knows the answer to that.
I don't, but we'll see what we can find out about that. A diagnostic tool that's really important, without a doubt. Okay. So we are exhausted, I can tell. I can see that. I'm going to offer to my committee that I will stay here. I'm going to volunteer Sarah. We'll stay here. We'll listen because we said, you know, we would be here for public comment. If y'all feel like you need to leave and get on with life, I certainly understand. I think you've done a great deal of listening today, and I appreciate it very much. So as far as the formal part of the committee, we'll somewhat adjourn in a sort of adjournment posture and just wait to make sure that there isn't someone that comes swooping in here and has something they really wanted to share with us today. So officially, the meeting is adjourned, and I look forward to seeing all of you soon, in a day or two.